Thank you for being early at the Saturday morning after a wonderful party. I have the honor to introduce Claire Schilling. I think she is, last week I was in North Sea Jazz Festival, and you have the artist in residence, and that means that the artists pop up everywhere with different people around. I think Claire is one of the artists in residence in this conference because she popped up everywhere. A lot of co-workers of her present things on sentinel node lymph node biopsy. I know Claire for a long time, when we did the Central, and of course with her mentor Mark McGurk, and starting to do the Central, had a lot of meetings in London, also at other occasions. And of course she is, she's one of the drivers of the guidelines, the consensus guidelines, the meetings organizing not only here but on other occasions as well. She published a lot on sentinel lymph node biopsy, I tried this conference to take the search function on the app and said Schilling, but I only had only the four I think where she was presenting or something, but not when one of her co-workers presented something. But I also have an official text. Mrs. Claire Schilling is Associate Professor of the Head and Neck Academy Centre in the Division of Surgical and Interventional Sciences at University College London, and Honorary Consultant Oral and Maxillofacial Surgeon at University College Hospital London. She completed oral maxillofacial specialist training, including a head and neck fellowship in the UK, as well as clinical research PhD in novel imaging, and that's where she's talking about, for detection of metastasis in head and neck cancer. She is chief investigator of the multicenter trial, LOC, for lymphatic mapping of oropharyngeal cancers. She's co-director of Head Start, the Royal College of Surgeons accredited national training program for sentinel biopsy in oral cancer. I think that's very important what she did, train all the others here in the UK. Her research and clinical interests included fluorescence-guided surgery, augmented reality surgery, and quality outcome measures. And of course, she will present today on sentinel lymph node biopsy. Please, the floor is yours, Claire.
Well, thank you, Remco. Oh, it is bright. Thank you, Remco, for that lovely introduction, and thank you, Richard and Andrew and the IAOO for inviting me to talk today. And thank you all for being here after the party, 8:30, I know, on a Saturday morning after a big event last night. I do appreciate you being here. So here's a couple of other people that I do appreciate, and I want to tell you a little bit about them and their role in me ending up being here today. So when I was at medical school, I really wanted to be a cardiologist, actually. I never even heard of maxillofacial surgery. But in a couple of weeks of being a medical house officer in a cardiology firm where the ward rounds started at 9 a.m. and finished at 5 p.m., and we were tinkering with doses of amlodipine, after a couple of weeks of that, I thought, this isn't really for me. I think I want to be a surgeon. So at that time, it was a bit late in the day to be applying for jobs. And the only job that I could get was being a senior house officer at King's College Hospital, which is the department of Rob Bentley. So my first day there, we were doing our handover in the ward round. An emergency call comes in. Somebody turned up in A&E with a kitchen knife up to the hilt, sticking out of their neck. And I thought, yeah, I think I'm in the right place now. So Rob Bentley was a wonderful mentor. I finished my rotation with him there for 6 months, and I said, I really, really enjoyed this, but it's a lot to go to dental school as well. I think I'm going to try some other stuff first. So I did orthopedic surgery, cardiothoracic surgery, general surgery, plastic surgery, and eventually I came back to Rob and I said, guess what? I think I want to do maxillofacial surgery. Will you support my application to dental school? And he said, of course. You know, welcome to the family. I'll do whatever I can to support you. So he wrote me a letter of support in applying to King's dental program. And that program was aligned to Guy's Hospital, which was where Professor McGurk was working. So I knew that Professor McGurk was there. I wrote him an email and I said, I've applied for dental school. Do you think I could have a chat with you about that? Have you got any tips for me? So that email was picked up by his famously protective PA, Marcia, and she immediately wrote back and said, well, look, it's nothing to do with him. He has no sway over who gets a place at the dental school. Even if you were his own daughter, he would be unable to help you. So I said, okay. So I turned up to my interview, and guess what? Professor McGurk was interviewing me. So we had a nice chat, and he offered me a place at the dental school. And he's very good at sort of following up on things. So he wrote to me afterwards and said, that was a nice interview. You seem keen. Would you like to get involved in some research projects? And that was the beginning of a very long relationship where he mentored me. And both these gentlemen have supported me at every stage of my career in coming through to specialist training and then essentially making a one-off or a two-off, really, job share program with another colleague where we could do a PhD alongside our surgical training. And you'll see, really, Mark McGurk's imprint throughout this talk that I give today. So, well, the project that Mark McGurk said, do you want to get involved in, turned out to be this one. And that was the next 10 years of my life. So this is the SCENT trial, and I'm not going to go through it in great detail, but you see that was published in 2015. And it gave me the opportunity to work with some of the fantastic people here, so Remco, Sandro, and let me tell you, their very blunt European feedback on my drafts for the publication were a very valuable education for me in how to write papers. So after 2015, the National Institute of Health and Care Excellence in the UK, NICE, recommended that sentinel node biopsy should be offered instead of neck dissection for T1, T2 cancers. And the level of detail that they go into when they're trying to recommend a treatment is huge. I mean, there's pages and pages of different scenarios that they consider with this cost-effectiveness analysis. So a whole range of positive rates of sentinel node, the additional cost of doing ultrasound in follow-up, or what about if you actually don't do any surgery on any of these patients? You give them radiotherapy instead and have a look at the recurrence rate. So across a huge range of scenarios, sentinel node biopsy dominated in terms of cost effectiveness. Now at that time in 2016, there weren't really many places that were offering it. So there was Guy's Hospital in London, there was here in Liverpool, and Jeremy McMahon's team up in Scotland. So NICE realized that they needed to have a strategy on how to roll that out. And Mark and I were invited to an implementation committee, and what we designed was based on really what the breast surgeons had done already, which was setting up a kind of lecture-based training program and then mentorship in rolling this out. So we knew we had to have a strong protocol. We knew we had to train the multidisciplinary team. We knew we had to support people in getting their RSAC licenses and so on. And we started this Head Start course. And in fact, Richard Shaw was one of the early lecturers on that course as well. But you see here the core lecturers. So we have Simon Wan, who's a nuclear medicine physician. We have Brian Bizaze from East Grinstead, Gary Walton from Coventry, Selvan Thavaraj, who is a pathologist from Guy's, and here's Michelle Vickers, who's from the Head and Neck Cancer Foundation, who helped support us in setting that up. And it was also accredited by the British Nuclear Medicine Society and the Royal College of Surgeons. And over the course of a few years, we went from a situation of 3 centres that were doing this procedure to 39 units that had come as teams to our lecture program, and then were able to go on and start validating themselves against neck dissections. And like a true cancer, shall we say, that program also metastasized, so we're able to offer training to centres across Europe, and it was gratifying to hear Stephen say that also helped form the basis of the validation program for his trial in the States. And now, more recently, we see that sentinel node biopsy is considered one of the markers of quality of a head and neck cancer service in the UK. So it's included in a metric in the GIRFT program, that's the Getting It Right First Time program. And most recently, just a few weeks ago, the quality outcomes in oral and maxillofacial surgery, the national audit that's supported by BOUMS, presented its data, and it shows that 60% of the units who are contributing data nationally to that audit are offering sentinel lymph node biopsy as a routine procedure. So we had already in this conference a fantastic lecture that was given by Stephen Lai covering trials in sentinel lymph node biopsy. So I'm definitely not going to be covering that again. And we had an absolutely brilliant day on Wednesday as well, with fantastic international interest in sentinel lymph node biopsy. There's just a couple of things that I want to sort of cover before I go into the main meat of the talk. So, I know that not everybody is a fan of sentinel lymph node biopsy. In many cases, people feel much more reassured if they've offered a neck dissection to the patient. They think, yeah, that's job done, I haven't taken any risks, etc. I just wanted to draw your attention to some data that we produced. So this was a retrospective analysis of over 4,000 patients who had a neck dissection that was pathologically staged, N0. Now, there's some heterogeneity amongst the groups of patients. We have T1 to T4 included in that, all pathologically N0. But even when you look at the patients with early stage disease, T1, T2, there's still a recurrence rate of 7.5% in those patients with a pathologically N0 neck dissection. And half the time it's in the neck that was dissected already. Second of all, one of my colleagues quite rightly pointed out that most of the patients who have a sentinel node biopsy will be negative, and they're the ones who really benefit from it because they have a small operation, they get back to their function more quickly, and they get on with their lives. But what about the patients who have a positive sentinel node? Then they need to come back as it stands, they have a second procedure, they already have, stage 3 disease, we're saying, and then we're putting delays into their treatment. Well, Jeremy McMahon, who's a great thinker about this, started an analysis where he took all of his data, he looked at the patients who were staged N+ by sentinel lymph node biopsy and matched it to a group of patients, again, clinically T1, T2, N0, who had a neck dissection, and also found occult metastases in that neck dissection. So he did a univariate analysis looking at the factors that seemed to influence survival, did a multivariate analysis and picked out those factors that had the biggest influence on the hazards ratio. So he had 4 variables and 6 variables. And then, along with a computer scientist, he designed this matched pair algorithm. So you can also join with this. That's it publicly available on GitHub. And what he showed was that matching at 4 variables and 6 variables in terms of disease-specific survival and overall survival, there was statistically no difference between the N+ by sentinel node or elective neck dissection. So we saw this paper, we collaborated with Jeremy. This was data that was presented earlier on in the conference, essentially bolstering that data already now to 70 matched pairs across both 4 and 6 variables, and again, statistically showing no difference in survival between those 2 groups. The final thing I want to say again before I get into the main meat of the study is, of the talk, is that pathology. Now, pathology, it's sometimes a stumbling block for being able to offer this technique to patients. It's a big change in practice for the pathologists. They see it as a lot of extra work. There's a huge amount of effort that has to go into a small number of lymph nodes. So we had a look at how things run for us in the southeast of England. So we have huge expertise at Guy's Hospital, as you see there with Salvam and the rest of his colleagues. And we send them our lymph nodes from UCLH, and they have 4 other hospitals that also send the lymph nodes into this essentially centralized service, so what we call this Southeast of England Consortium. And we wanted to check, does does this work for patients? Do we get results in a timely manner? And are those results accurate? And indeed, we saw in a kind of snapshot of 139 patients across these 5 hospitals that the turnaround time was pretty good, mostly within 7 working days. As expected, this upstaging result, and if we're looking at the survival of those patients, still very good for both the positive and the negative sentinel node biopsy patients. So today I'm going to talk to you about innovations in sentinel lymph node biopsy, and there's 3 areas that I want to cover. So improving surgery, expanding the indications of it, and then a look to some work that's ongoing and where it might take us in the future. So it's at one of these sentinel node conferences that Remco was talking about. I was looking around the trade fair, and one of the people there said to me, "Oh, are you a doctor or a surgeon or a scientist?" And I was a bit puzzled by that question, because I thought, well, I think I'm all 3 of those things. And actually, that's what inspires a lot of this work, because we see what challenges face our patients, we know the technical difficulties with the operations, and we're able to figure out how to get around those. And one of the things that you will see throughout this talk is that a solution that may have been inspired by a particular problem then also opens up other avenues where that solution can fit in, and it really feeds off itself, as it were. So let's go to improving surgery. When we do the imaging procedures for sentinel lymph node biopsy, we get these pictures. So the lymphoscintigraphy here on the left-hand side and the SPECT-CT. These are great at localizing hotspots, but what you see here is not what the lymph node itself. You're seeing just the tracer, and that image is much bigger than the node that you're trying to find. Now, I'm very lucky to work with Simon Wan, who does these beautiful 3D renderings from SPECT-CT, and he puts in some of the relevant anatomy, and that's very helpful for me. And just as a side note, look at how much variation there is in the drainage patterns from all these patients who have lateralized tongue tumors. You can see a massive amount of difference. So Sudha came to us as a PhD student. She's now finished successfully her PhD, and she's a successful consultant at Bristol Hospital, and she's continuing the work that we started looking at this virtual reality guided surgery. You can scan this QR code to get the image on the right-hand side, and I apologize for this video because this is me kind of like trying to do it on my laptop. It's much easier actually on your phone. But the idea was that we took those SPECT-CTs, we took the pre-operative MRIs and CT scans, we saw where the lymph nodes were, and then gave a realistic model of where we're going to find those lymph nodes in relation to critical structures. You can see here now the lymph node that we can clearly see, a nice long one just behind the IJV, near the sternocleidomastoid muscle. And having that kind of mental map really helps the surgeon, and especially it helps trainees who are coming in to do that technique. Here you can see another example. Here the model is being overlaid on top of the patient, but we're very far from being able to co-register a patient with these kind of models in theatre. But in terms of accurately targeting those lymph nodes, knowing what we're expecting to find, how big that lymph node is and exactly where it's going to be nestling in relation to other structures is fantastic. Now, we took this further, and Sudha did a lot of work looking at how we can enable clinicians to use this kind of software to make these 3D models here in the setting of reconstructive surgery. So we first of all did some work in designing a training program, showing clinicians how to do it, and then testing them for speed and accuracy against technicians that make the models for us for virtual surgical planning for our reconstructive cases. So having this degree of flexibility is great, and you can see here, again, now clinician-led planning of a fibular flap with multiple segments, and she showed that using this head-mounted see-through device was very good in terms of accuracy, even compared to the cutting guides that have been made for that same case. This has the potential to allow flexibility in changing the plan. For example, if you have a patient who comes and the tumor has changed considerably since your planning, and sometimes they do, your plan then no longer works. Well, actually, even the night before, okay, it's going to take maybe an hour or so, you could plan your resection of your mandible, and you could use your plan then, and here you see a cadaveric model that she's superimposing those segments onto. More recently, this is again just, I think a couple of weeks ago, a publication with Simon Morley from our group, who also spoke here today, and Mark McGurk, looking at using these kind of 3D models in parotid surgery. So they developed a protocol where you can see the facial nerve, and it's actually quite hard to prove the usefulness of this kind of technology. It's intuitive that it helps you, but being able to show how that reduces the either stress on the surgeon, the timing of the operation, is difficult. So this analysis was looking at surgeons who looked at the models before doing the operations, and it showed that actually they changed their plan 55% of the time based on what they saw on these models. Here, looking at how much they agreed about the complexity of those models. So the bigger the circle, the more agreement there is between them. And here you see a grading scale for complexity of the surgery, and then comparing that to the actual operating time. And absolutely, as they say, yeah, this is more difficult than perhaps it looks in the 2D. Indeed, that correlates with the operative time. So the next thing that helps with surgery, you know, seeing is believing, is fluorescence-guided surgery, and that's become pretty standard, I would say, or common at least in reconstructive surgery. It's very helpful for seeing the vessels going into your flap, particularly if you're raising perforator flaps and so on. This wouldn't be a talk by a surgeon unless I showed you a big hole that I'd made. In fact, this is my colleague, Luke Williams. It was very nasty. Oh yes, this is me being very excited about the flap I've raised. So here we've got a squamous cell cancer that's eroded through the cranium, and with also multiple nodes in the neck. I've raised this huge big bit of tissue to cover the defect, so a chimeric latissimus dorsi with a scapular, serratus component to it as well, and we're checking the vascularity of that flap. And actually this was useful because we could see this flap was so long that this edge of it was not perfused, so we're able to remove that and ensure that we gave a viable flap to the patient. Now, aside from using it in oh, it's counting down, that's lucky. I thought it was counting up. Aside from using it in reconstructive surgery, you can also use it for sentinel lymph node biopsy. So this is the group from Tessa Buckle who developed what they called a tracer cocktail injection for the sentinel lymph node mapping, which sounds very exciting. So what they did was they took the nanocol, so the backbone of the colloid, to which technetium is attached. So here you have your regular tracer, and then mixing it with ICG. And what you get is a non-covalent bonding between those two things, and then you have a tracer cocktail that's good to go. It's got both the tracers on it. Unfortunately, this video doesn't work. So the science mind says, okay, well, that's really cool. Can we make that any better? And this was some early work that we did with one of our MSc students, when we're still sort of in the King's Guise axis. So we wondered whether we might be able to make this mixture a little bit brighter. So we know from mass spectrometry that you get about 8 molecules of ICG attached to each nanocolloid. Well, we thought, if we thermocycle it, could we open that up and then attach more ICG molecules to it? And by the way, thermocycling is just the fancy word for we heated it up more than once. So we did that, we heated it up more than once, and we wanted to see, can we get more ICG molecules attached to it? And actually, although it does look a bit brighter here, when you come down to actually looking at the fluorescence signal in a standardized way here in a very black box, there's no significant difference. And in fact, that's quite good in a way, because when you start doing something like this and messing with a molecule, you're essentially creating a new drug, and that's a whole bit of a headache. But we thought, okay, is there another way that we can potentially improve on this, taking advantage of this kind of quirk of chemistry? So this is what I do every time I do a sentinel lymph node biopsy. We take the regular radio tracer, so nanocolloid, and we label it with ICG. The patient has their scans. I go and sit with Simon Wan. We have a look through that, and I decide where I'm going to take those nodes out from. Then he gives me a pre-made kit now with the leftover nanocol, so from here, without the technetium on it, to which a mixture of ICG has been made. So now I have a second tracer that's a labeled colloid that I inject in theatre, so 2 sets of injections. And what's really great about this is that I then know when I'm in theatre, if I have a node which is hot and which is green, that's going to be the sentinel lymph node. And how does this work in practice? Well, here you see a case where the patient's had a ventral tongue tumor injected, and the worry always for us is this a shine through, or is that a node close to the tumor just up here? Now, this patient is extremely thin, so we don't always see the signal through the skin, so just bear that in mind. But you can see here, I've injected now with the colloid. There's absolutely no signal there in the level 1. And when I use my gamma probe, you can hear that that's got the dual signal in it. Now you're saying, oh, but you've got some stuff down there as well, haven't you? And indeed, so although the ICG does attach to the nanocol, you do get some dissociation because it's in plasma and it will attach to plasma molecules as well. And so we get some second echelon nodes, but what's key is that there's no radio tracer in there. So we absolutely know that those are second echelon nodes, and there's just one sentinel node in this case. Now, when we have this dual tracer in the nodes, the other thing that we noticed is that there's a differential signal across the node itself. And I think you can hear. You can see both with the fluorescence and with the gamma probe that that signal is really located to the hilum, which is kind of what we expect. We know that that's where the lymphatic fluid comes in, and as Sandro talked us through on Wednesday, that's where we're most likely to find the metastases when we're sectioning the lymph node. But it's not always the case that the highest signal is at the hilum of the node, and you can see here a number of patterns where there's differential radio tracer and fluorescence within the node, and I'm going to come back to that. So the second part of the talk is about expanding indications. And, you know, medical research, a lot of it has come from drug trials, right? And that's quite a rigid process in order to undertake those clinical trials. So there's a set process, your protocol, there's no deviations, there's safety checking and so on. But it's become more and more recognized that surgical trials just can't work under that same strict protocol. So there's a process called the IDEAL framework, and that's an acronym for Idea, Development, Exploration, Assessment, and Long-Term Study. And it's really set up for surgical innovation, and it gives you the chance to allow changes, iterative changes within your protocols that you can do based on your experiences, your first experiences. So we applied this framework to developing sentinel lymph node biopsy for salivary gland cancers. Now, at this time, there weren't very many reports about it. The biggest series, I think, was 6 patients, and in that series, they injected 8 times around the tumor in the parotid gland. So we thought, well, 8's a lot. Let's start with 4, because that's what we do for mouth cancers. So here you can see the tumor in the parotid gland. Here's the needle coming in here, and under ultrasound guidance, we're putting 4 blebs of radio tracer around the salivary gland, around the salivary tumor, sorry. So first of all, what we saw was that the gland completely filled up with tracer, but eventually we did see drainage to this level 2 lymph node, and we were able to retrieve that. For the second case, we thought, okay, let's make this iterative change that we've allowed within our protocol. We're going to inject this time intratumorally. And what we really wanted the endpoint of this study to be was the ability to find periparotid and intraparotid lymph nodes. So clearly that's not going to work if the whole gland is lighting up. So here's our second case, and we've injected it directly into the tumor. And again, we're seeing, oh, okay, the whole of the gland is lighting up again. But by the time we come to theatre, and here we're using freehand spec, which again, I'm going to talk to you about shortly, we can see there's 2 areas. So the first is the tumor within the parotid gland, and here we're navigating down onto an intraparotid lymph node. And from a sort of sentinel lymph node nerd perspective, there's nothing nicer than being able to see a lymphatic channel going into a node, and maybe it doesn't project brilliantly here, but actually this is the parotid gland that's being removed. The injection site is down here. We've got some fluorescence in there as well, and you can see this periparotid lymph node with the little tail coming off it. So that's showing us that drainage to those lymph nodes, and we published our results on where these sentinel nodes are in the parotid gland. We also did some non-parotid salivary gland malignancies. Now, what's difficult about sentinel node biopsy for salivary malignancy is that you have so many different pathological subtypes. And for squamous cell carcinoma, we're very well versed in using cytokeratin markers for immunohistochemistry. Actually, your pathologist needs to be a bit agile in what immunostains you can use for those different types of salivary malignancies. But I think this is something that's going to become even more important, and this is a paper that was published recently looking at reevaluating really the nodal staging for salivary malignancies. It makes a very good point that the staging system that we use is based on squamous cell disease. And actually, salivary malignancies are very heterogeneous and they behave differently. So the suggestion in this paper is that actually the role of intraparotid lymph nodes, the number of lymph nodes, and the combined size of the metastatic deposits seem to have a better indication of survival than just the current T and M staging. So having a technique in which we can find those intra and periparotid lymph nodes may become even more important. Now, we're very used to injecting oral cavity cancers, and it's pretty easy because you can see the tumor and you can inject around it like this. But what about for patients where there's more inaccessible tumors? If you have to put the patient under a general anesthetic in order for them to have those injections, then it's pretty difficult for them to then go and have their lymphatic mapping in the nuclear medicine department, tying up a lot of people if they're still under a general anesthetic. Is there a way that we can circumvent this and potentially then use sentinel node biopsy for other indications? So this is where freehand SPECT comes in. So this is a device in which there's a gamma probe. You have your fiducial markers that are attached to that. You have some fiducial tracking devices that are also attached to the patient. And I should say, the tracking is done by near infrared. So if you're using fluorescence with this, you get a lot of twitching on your fluorescence camera. So something that we've learned along the way. But anyway, so you're picking up these hot spots in the neck, and in almost real time, what you're seeing is these hot spots that are being calculated and then projected onto a screen. So you have like a mixed reality picture that's coming up. So you can see where those lymph nodes are. This scan takes about 2 minutes. It's really, really quick, and it's repeatable. You can do it as many times as you like. So we thought, yeah, this looks fun. Let's see what we can do with it. So the first thing is to see how it works. So here you can see a patient with a floor of mouth tumor. They've been injected in the outpatient department in the usual way. Then we've scanned them with a freehand SPECT, and you can see how those nodes are being tracked with the patient as he's moving. So we designed a study where we were blinding ourselves to the results of the usual imaging, so the SPECT-CT, and the lymphoscintigraphy, and actually only using the freehand SPECT to do the sentinel lymph node biopsy in oral cavity cancer. So you can see a sample case here. So this patient has had their SPECT-CT. They've got 1 node at the top and 2 at the bottom. You can see that on the lymphoscintigraphy. So they had a marking there. We took the picture. We saw where it was, took the markings off, and then the patient goes to theatre. The surgeon is blinded to these results. They're instead using the freehand SPECT, and here you see exactly the same areas have been highlighted. So in this protocol, the sentinel node biopsy was done with freehand SPECT, and only at the end of the procedure was the results reviewed and any discrepancy was dealt with. And what we showed was across 50 patients, there was a high rate of concordance between the freehand SPECT and the preoperative imaging. And actually, in all of those spheres, the total number of lymph nodes, the number of positive nodes, and the false negative rate, the freehand SPECT performed better than the other modalities. So we felt that this supported the intraoperative use of freehand SPECT. Now that opens up the freedom to be able to offer sentinel node biopsy to patients where this injection has to be done in theatre. And that's led on to the LOOK trial, stands for lymphatic mapping of oropharyngeal cancer. Now the background to this is, of course, we have an increasing incidence of oropharyngeal cancers. We know many of the patients, particularly those with HPV-related disease, will present already with lymph node metastases in the ipsilateral neck. But because of that, many of them will get treatment to both sides of the neck. And these patients have a long survivorship. So the question is, can we personalize the treatment to the contralateral neck by using this technology? So this trial opened, early 2020, which is another story entirely because, of course, that was a bad time to open a trial. So we've had a few delays, but essentially we're getting there. So this trial has now got two phases in it. So the first is an imaging phase, and the second is a surgical phase with a go, no-go gate in the middle. The inclusion criteria are patients with newly diagnosed oropharyngeal cancers. That's all subsites, so that's soft palate, tonsil, tongue base, pharyngeal wall, and so on. Any HPV status, but they must have ipsilateral positive lymph nodes. They're excluded if they've had previous treatment to the neck. This is not because lymphatic mapping doesn't work, but because we really want to see what is the true contralateral drainage rate. And of course, if they've got distant metastases and they're not going to be going for curative treatment. Importantly, there's no exclusion if they're in another trial because there's some overlap, in fact, complementary data that would be gathered with Pathos, but of course, Pathos is now shut, so no longer an issue. So in the imaging phase, the patients come into theatre, and we're essentially opportunistically injecting them in the operating theatre. So they might be coming for an examination under anaesthetic to see their suitability for robotic resection. It might be that we think we can see where the primary is on the imaging, and they've got an FNA positive lymph node, but we just want to be sure we're going to get a biopsy of it. And one of the other things that we can offer to patients, if we know that they're actually not going down the surgical route, but they're going to be going for chemoradiotherapy or radiotherapy, is to extract teeth. And patients actually really prefer that if we can do that rather than them coming back to have it done under a local anesthetic. So whilst they're asleep, we give 4 peritumoral injections of, well, it was lymphoseek, now it's the investigator's choice, of radiotracer. We wait 15 minutes for that tracer to go to the contralateral neck if it's going to, and then we perform a freehand SPECT scan, so that imaging that you saw. They then wake up from their general anesthetic, and before they go home, or up to 24 hours later, they have a SPECT CT, so that kind of gold standard gantry-based radio imaging. For most patients, that's it, but we've also built in a sub-study that I'll describe to you. So the outcome for this imaging phase is the primary outcome being the rate of contralateral drainage. So how many patients are we getting drainage to a lymph node on the contralateral neck by any imaging modality? And we need to have at least nearly 30% of them to make it worthwhile to go on to the next phase of the study. The secondary outcome is how accurate is this, the freehand SPECT, bearing in mind that we're imaging them pretty quickly after injecting a relatively high dose of radiotracer. Is this going to allow us to pick up these contralateral nodes in theatre? So we're comparing the accuracy of this then to the SPECT CT. The sub-study is giving us another kind of possible protocol if that one doesn't work out. So in patients who've got tumours that you can clearly see when they open their mouth, we're inviting them to come back for a second injection of radiotracer, and this time, not giving a peritumoral injection, we're giving them one single injection into the tumour itself. And they then go on to have a SPECT CT. The second important part of that process is how do patients feel about it, because they will have had both the general anesthetic injection and then this local anesthetic injection, so that they have a topical spray before they have the injection. And we had a questionnaire that was designed by our patient group that's going to answer that question. Is it okay for patients? So the outcome for that sub-study is then what's the rate of contralateral drainage of the SPECT CT on the first instance, and then how comparable is the 4 injections under general anesthetic to the 1 injection in the outpatient department setting. And then the final phase of this study will be performing a sentinel lymph node biopsy on that contralateral neck node. And the protocol that we will use for that will depend on what we have found in the first part of the study. So either injections under general anesthetic or in the outpatient department. And we've just published the protocol of that. We're recruiting, and I hope that we'll be able to close that first phase probably nearly at the end of this year, so we should have some initial results there. So that brings me on to the final part of this talk, and this is kind of a little bit more like blue sky thinking, where are we going with this? So the thing that strikes me is that we're very proud about looking for the needle in the haystack. That's what he's doing there. We have this lymph node, we're sectioning it, and we're finding these very early metastases. Well, actually, are we receiving all the information that this lymph node is telling us about? Because let me tell you, and the studies have been done on this, if you inject a patient on a Monday, you'll see these sentinel lymph nodes. If you inject them the following Monday, you'll see those same lymph nodes. If you inject them standing on their head, you'll see those same lymph nodes. So there is something that we are showing about the communication of those lymph nodes with the primary tumor that we are mapping with this technique. Here's one possible explanation. So this is a really interesting trial where they took the foot pads of mice, and they injected one with a sham, and in the other they injected this metastatic melanoma model. Now, this model, these cells would metastasize reliably, I think at 12 days after injection. And what they did was took out these lymph nodes at various days. So you can see here the control lymph node, and we're looking here at lymphatic vessel density, and we're looking at blood vessel density. In the control, there's no change. But in the pre-metastatic lymph node, so bearing in mind, before there's any cancer in there, we're seeing a massive increase in the lymphatic vessel density, and that continues when there's a defined metastases in there. Now, I think that this is something that we see also in clinical practice. So here's a patient who had a lateralized tongue tumor, and we injected it, and they had 2 sentinel nodes up here, and another one down in the neck. So actually not that unusual, but what was unusual was that when we looked here, there was no metastases from the mouth, but there was a thyroid cancer in this lymph node here. So we had to look back at our data and we realized that this had happened more than once. So this is a patient that had a left tongue tumor that was injected back in 2019. At that point, sorry, I didn't have those fancy scans, but essentially this is a sentinel node very low down in the neck. They then came back with another mouth cancer. Sorry, what I should say is at this point that was felt to be a second echelon node. It wasn't dissected. So they came back with a second mouth cancer, and when they were injected again, a few years later, this node still showed up again. And when we removed it, guess what? There was a thyroid cancer in there. So we went to our consortium, we went to guys, and we said, have you seen this a few times? Have the other hospitals also seen this? And we did a retrospective analysis across a few years. And we found that there were 10 procedures in 9 patients. So apart from the one that you've just seen, because that node wasn't removed the first time, there was another patient who had sentinel node biopsy twice. And on one of those occasions, they mapped to a thyroid cancer. And in 3 cases, also detected oral squamous cell metastases. And you can see here the distribution of where these sentinel nodes are. So, injected in the mouth, and as expected, we're getting nodes high up in the neck that had metastases from oral squamous cell carcinoma. And down here, much lower in the neck, we're seeing these ones with thyroid cells or thyroid cancer in them. We wanted to compare to what would be expected to be found in neck dissections. So we looked at the number of neck dissections that were performed over that same time period. So huge number, 726. And only 6 of them had these thyroid cells within them. Now, of course, it's not directly comparable because you're not serially sectioning that neck dissection, but still, it's enough to make you think that there is a difference there. And actually, is what we're seeing, oh my gosh, I'm so sorry, my phone's ringing. It's actually what we're seeing is this increased lymphatic vessel density, which is responding not only to perhaps a squamous cell cancer in the neck, but another cancer in the neck that's drawing that tracer into there and showing us where these hotspots are. can we, in fact, use lymphatic vessel density as a marker of what's going on within those lymph nodes? Now, some work has been done on this. This really nice paper, which was looking at lymphatic vessel density and high endothelial venular density in metastatic and non-metastatic sentinel lymph nodes. And it does show that there is a significant difference between those. Is, in fact, this a possibility for us not to be looking for that needle in the haystack and showing those small number of metastatic cells, but actually looking at the architecture of the lymph node instead? And that's led on to some work that we're doing. Here we go, another big chop case. So this is a patient with a very neglected cancer who had a fungating tumor coming through their chin, floor of mouth, tongue. They had neoadjuvant chemotherapy, they had tons of positive nodes. In fact, he's doing brilliantly. Nice double flap reconstruction, and he's still alive. But what we knew was that we were going to be radiating everything. So we asked our pathologist, please, can we just take a few core biopsy specimens from what we know are negative and positive nodes within the neck, and send them to our partner team at the Francis Crick Institute, where they have a micro-CT. And the idea is moving towards perhaps an on-table diagnosis of these sentinel lymph nodes using this technology. So micro-CT, you can get sub-millimeter resolution, sub-micron, resolution within the lymph node. We might be able to see these architectural changes that herald a pre-metastatic or metastatic lymph node. So this is work that is still ongoing. But taking this even to a deeper level is looking at the architecture of the lymph node enough. What about what's actually happening at a genetic and protein level within the lymph nodes? And again, not my work, but it has been done looking at the changes in gene profiles across lymph nodes in the neck. And here you can see a whole number of genes that have been investigated by neck level. What's fascinating is that even in a neck that has no metastases or no cancer associated with it, you have a different profile and expression across those neck levels. And the authors here suggested that actually, what we talk about skip metastases, or why things metastasize very rarely to certain levels of the neck, is not because it's not ready to catch it or it's so far away or all the rest of it. It's just the niche is not ready to receive metastases. You won't get it there because it's not set up to have a metastatic deposit within it. So what we also see is there's changes within the gene profiles in these metastatic and non-metastatic lymph nodes. This is some work that's come out from Sheba Ershad's lab at King's, who we're looking to collaborate with, and she's done a lot looking at the profile within tumor-draining lymph nodes, and that's really what we're talking about, sentinel nodes, tumor-draining lymph nodes. That relationship between the node and the cancer itself, we know it's a two-way street. We know those immune cells, those T cells, are trafficking between the cancer and the lymph node. And she is working towards looking at aspirating these tumor-draining lymph nodes and seeing what the immune cell population is within there to predict response to immunotherapy. Now, that's something that we're also thinking about, and here you can see a review article that Carl Payne, who's just finished my research fellow, and is coming to work with us very soon, so we'll be continuing this. But asking that question, actually, we're mapping a relationship between a lymph node or 2 or 3 lymph nodes and the primary tumor. Are we doing the right thing by saying, hey, great, we can find a small metastatic deposit in there? Actually, I think there's a lot more that we can learn. And what we're doing is taking these primary cancers, we're taking historical samples of patients that we have who have had sentinel lymph node biopsy, and we remove more than one lymph node, so we have a metastatic lymph node and a non-metastatic sentinel or tumor draining lymph node in the same patients, and we're using these. So this is COSMX or nanostring, looking at the cell profile and relationships between them, seeing if we can see a difference between those immune cell populations in metastatic and non-metastatic lymph nodes. Now, again, this is very early work. Carl has kindly sent me these pictures that he ran through the lab just last week. But we've optimized a panel looking at healthy tonsil tissue, looking at a number of markers for both B cells and CD3 T cell populations as well. this is where we think we're going next, is not just doing an operation and removing these lymph nodes, but working out what it is they're telling us. So that's it from me. So again, thank you very much for the opportunity to talk to you today. And this work is not possible without this team of people, and more to come. Thank you.
Thank you very much, Claire, for your extensive, very wide, very different things in sentinel node biopsy, not only sentinel node biopsy, but everything in guided surgery. We have some, of course, some presents, but maybe there's time for question. I forgot, sorry. I cannot see if there are questions. Is it clear? It was, of course, an overview of all the things Claire does and was thinking about. No? Okay.
Still recovering from the party.
Claire. We have a new photographer. On the scale? No. You can do everything with iPhone. There's something else, of course. You know this one because you handle it to many people. But there's something else. You have to open it?
Okay. Oh, wow. Okay. Fantastic. Right. Thank you. I don't think my husband's going to like this because he's an Arsenal fan. So.
He's an Arsenal fan. Oh, so you wear it at home.
Okay.
Okay.
Depends if we're getting along or not. Thank you.
And all importantly.
Oh.
There we go.
Thank you.
Thank you very much, Claire.
Thank you. Thank you.
We continue with some free papers. I think first, let's see where the program is, sorry. Well, I think Fernando is first. Yeah, Fernando. The first presentation will be on predictive scores of cervical metastasis and distant malignant tumors of minor salivary glands of the oral cavity, oropharynx, treated at the National Cancer Institute. Please, Fernando.
Thank you.
Yeah.
Well, good morning, everyone. Thank you for the opportunity to show this free paper presentation, this important session. So the aim of this presentation is to identify predictive factors in cervical and distant metastases in minor salivary gland cancers, and to try to create a predictive score to prevent or to identify this possibility. So none of us has any disclosure to make. So we know that the heterogeneity of series in salivary gland cancers, as well as the paucity of huge series published in the literature, it prevents the identification and the practical use of predictive factors for metastasis. So we would like to present our clinical diagnostic tool that can be used throughout therapeutic plan of patients with minor salivary gland cancers, particularly of the oral cavity and oral pharynx. So this is a retrospective study of 437 patients treated in a single institution in Brazil between 1995 and 2050. And we try to identify the factors associated with cervical metastasis and distant metastasis. So the clinical and demographic data of the 427 patients, female patients younger than 60 years old were the most frequent found with tobacco smoking history. Most of the patients had tumors of the oral cavity, particularly from the hard palate. As far as the histological types found, adenocarcinoma, adenoid cystic carcinoma, and mucoepidermoid carcinoma by far were the most frequent in our series. And almost equal incidence of low-grade and high-grade tumors. Most of these patients had clinical staging in the initial staging of disease. Most of the patients had surgery with curative intent, followed by radiation therapy, and we were able to offer negative or close margins in 86.7% of patients. But when we look at histopathological data, most patients became those with a higher T stage and 0. Most of the patients had more or higher than 1 centimeter thickness of tumors. And most of our patients did not have bone involvement, perineural invasion, lymphovascular invasion, neither distant metastasis. So, creating an agreement analysis between clinical and histopathological staging, we found that we correctly estimate the stage, clinical stage. In 49.2% of cases, we underestimated the stage in 42%, and we overestimated the stage in 8.8% of cases. So in total, we had 20.1% of metastases found, 11.4% of cervical metastases, 6.6% of distant metastases. Oropharynx was the site with the higher percentage of metastasis, and the oral cavity, the most frequent site for distant metastasis. So we evaluated the factors with cervical and distant metastasis, and we found that for cervical metastasis, adenocarcinoma, the subsites of base of tongue, floor of mouth, the clinical and positive stages 3 or 4, and the presence of lymphovascular invasions were statistically significant in the multivariate analysis. So to develop a predictive score after identifying the main factors associated in the multivariate analysis, we devised the development of a predictive score for metastasis by assigning weights for these factors. So, doing this, each one of the factors identified in multivariate analysis, they had their own weight in this score. And in the ROC curve analysis, with a sensibility of 86% and the specificity of 70%, we found that a weight of equal or higher than 5 points could be predictive of lymph node metastasis with an odds ratio of 15.3. Looking at the possibility of distant metastasis, tumors located at retro-trigon area of the mouth, adenocystic carcinoma, N and M clinical positive stagings, TNM staging 3 or 4, and the presence of the ulceration of the tumor were important in the multivariate analysis. We did the same type of statistical analysis, and the ROC curve with a sensibility of 92% and a specificity of 65.2% found that a weight higher, equal or higher than 7 points, could predict the occurrence of distant metastasis with an odds ratio of 21%. So we believe that the building of this predictive score could help us to suspect the presence of either cervical or distant metastasis, and maybe we can use this as a tool for the indication of elective neck dissection in this setting. Thank you for your attention.
Thank you very much, Fernando. Are there any questions from the floor? I have a question for them. Do you use it nowadays already in clinic?
Excuse me?
Do you use your model already in the clinic now?
Not now. What we did, this is a part of the main author is my pupil. Pupil? That's how you spell.
Yeah, I understand.
And master degree course at the post-graduation course, part of the Brazilian National Cancer Institute. And we started trying to identify the patterns of lymph node metastases and distant metastases in this group of minor-thyroid gland cancer patients. So we identified then where the metastasis goes, and after that we had the idea to, this is an important number of patients, to create this predictive score. We are not starting to use this until now, but we plan to.
Yeah, because it is a really impressive number of minor thyroid gland tumors, because it's a rare disease and you have
a rare disease. You're right.
Many.
You're correct.
Questions from the floor? Others? No? Thank you.
Thank you very much.
Then we continue with the second free paper. Is Chris MacDonald, and he will talk about patients' priorities and quality of life following sentinel lymph node biopsy and elective neck dissection in oral cancer. We have heard Chris many times before in this conference about the methods, etc. So I'm looking very forward to hear the results of your research. Thanks.
Thank you. It's been a slow drip of results over the last few days, so hopefully we'll round it off just now. So, yeah, I'm Chris MacDonald. I'm a consultant maxillofacial surgeon in Aberdeen Royal Infirmary. And I'm going to talk about some work I did while I was a trainee here in the Liverpool head and neck unit. And we're thinking about sentinel node from a slightly different point of view. As we've heard a lot about at the conference, as best we know, there's no difference in survival between sentinel node biopsy and elective neck dissection, accepting the work and kind of increasing the certainty of that observation is ongoing. So in lack of a survival difference in this patient group, then other things must become important in patient decision-making, and in us understanding what we need to research and how we explain these procedures to patients to facilitate decision-making. So we started thinking about that when we were looking at doing some non-survival research and survival with outcomes other than survival in sentinel nodes. So we started with a literature review, and we published this a couple of years ago in head and neck. And I think the big outcomes for this was, 13 studies, over 1,900 patients involved in there. 30 different outcome measures assessing differences between sentinel node and elective neck dissection. But what we really didn't have was one very good trial that showed differences in clinical and statistical significance between elective neck dissection and sentinel node biopsy. Absolutely, definitely hints that shoulder neck morbidity may be important, that appearance may be important, but no real killer blow in there that we could nail down. So the question, I suppose, is why is that? Well, it could be that there is no difference in these outcome measures between sentinel node and elective neck dissection. We need to keep that in mind. However, it could also be that we're not asking the right questions, or we're not asking the questions in the right way. The quality of life measures generally used in the past have been designed and validated for patients with more advanced disease. And it seems entirely possible that the priorities for this group may be different than they are in early oral cancer. So we thought that would be interesting to have a little look at this. So we did that by taking this right back to patients and trying to forget everything we think we know and taking it right back to patients. And I did this work with Dr. Lucy Frith, who's a qualitative researcher here in the University of Liverpool. So the idea was that we would do qualitative interviews. So I went off and did a course and learned how to do that. And we set up a structure of how we were going to do these interviews. They're semi-structured, so we had some things we wanted to explore with patients. But patients really had an open forum to bring anything to this interview at all. We had a really clear structure. I won't go into the ins and outs of it, of how we were going to record and analyze this data to make sure that we didn't put our imprint on the data, that this was data that came from patients, and we let the patient's stories build a picture of what was important to them. So by the time we reached both kind of data and theoretical saturation, we'd covered, I think, a fairly broad and representative range of sentinel node, including negative, positive with completion net dissection, and false negative sentinel node. We did also include patients after watch and wait because I think they are an under-researched group. They are still there, and I think it's important that we keep them in mind as we go through this. What did we find? Well, I think the biggest overall takeaway was this, that patients that had surgical staging for the neck, either with sentinel node or with elective neck dissection, felt the benefit that they got was worth the morbidity that it brought. So overall, surgical staging was worth it. Now, the nature of the benefit that they described was usually talked about in terms of a reduction in fear of recurrence. But patients highly valued that interaction in clinic where they could sit down and know that their own lymph nodes had been looked at by a pathologist and hadn't found tumour. That was incredibly valuable to patients. That was also valuable to patients in sentinel node biopsy where tumour was found, because they felt that it was worthwhile looking and they felt that they may derive a survival benefit from it. So overall, surgical staging is valued by patients. Other things that we found, appearance change was a very common theme through all the groups. Patients whose appearance were changed by surgical staging didn't like that. Appearance change is multifactorial. Things that patients said were important to them were length of scar was important. Appearance of scar was important. Contour change after neck dissection was important. And they also felt not only was it important to their experience after surgery, but they felt it would be important to their decision-making if there were differences between sentinel node and elective neck dissection. So appearance was more important than I thought it was going to be. Shoulder mobility was also important in the patients that had it. Now, that was almost exclusively in the neck dissection group and the cohort we studied. Patients described shoulder mobility in terms of a quality of life problem. They didn't say, this shoulder's got a range of movement here, this one's got a range of movement here, and that's a problem. They described the impact it had in their life. And building on something we talked about the other day, I would suggest that when we think about shoulder mobility and we measure shoulder mobility in this patient group, we should do so as a quality of life problem. Patients felt differences in shoulder mobility, if there were differences between sentinel node and elective neck dissection, would be important in their decision-making process as well. Lymphedema was raised as an issue by some patients. Tended to be transient and in the elective neck dissection group. They didn't like it. It was unpleasant. It was something that they felt they wanted to avoid, and again, would have been important in their decision-making process. Sensation change was present both in sentinel node and elective neck dissection, and patients didn't like it. Now, the literature on sensation changes after surgery is very mixed, but the patients we interviewed very much described it as an unpleasant experience that they would like to avoid, and something that may impact their decision-making if there were differences between groups. Pain was a theme that came up in 3 separate ways. In the sentinel node group, pain of injection of at the time of radiotracer was memorable and unpleasant. Now, at the time we did this, we didn't give local anesthetic when we were doing injections, and you could say, okay, simple fix. Pain with surgical drains was talked of negatively, both as physically painful and as a distressing thing. Not in everybody, but in some patients. And some patients felt the presence or absence of a drain would be an important aspect in them deciding which treatment modality they would want. Now, here in Liverpool, we use drains in neck dissections, as you do, but it would be very unusual for a drain after a sentinel node biopsy. Pain in the long term was talked of exclusively in terms of shoulder morbidity. Patients didn't like it. Patients felt that if there were differences between groups, that would impact their decision-making. Other things that came out, I touched on the value of pathology. Patients that had surgical staging, either by sentinel nodes or elective neck dissection, placed a very high value on having the pathological analysis of a specimen. And that did reduce fear of recurrence, as they described it as reducing fear of recurrence. So that's an incredibly valuable interaction that they had there. Decision regret was not a feature of these interviews. Now, there's one study that suggests that after patients with sentinel node biopsy, decision regret may be a feature, but we didn't find that. Patients that had negative surgical staging by sentinel node or elective net dissection, saw that as a successful operation, not as a needless operation, okay, for some of the reasons we've talked about. Even the patient that had a false negative sentinel node biopsy valued the opportunity they had to try and avoid neck dissection. And when it came to them needing a neck dissection, they knew they needed it, and their priorities shifted away from somebody with no metastatic disease to somebody with a more advanced cancer, and they felt they still made the right decision. The theme of the biggest operation I found really quite interesting, and this was exclusively in patients that chose neck dissection. This came up quite early in the kind of interview schema, and the way we incorporated it in the interviews going forward was we painted the picture at the end of an interview is that we've got two operations, for argument's sake. We have a small operation and a big operation. Now, the end point for survival is the same. Okay. The big operation means spending longer in hospital. It's going to give you some shoulder problems, change of appearance, and complications, more complications than the smaller operation is going to do. Which of these options would you like, given that survival is the same? Now, fairly predictably, the sentinel node cohort tended to say, well, I want the small operation because the survival is the most important thing to me here, and that's going to be the same. But a number of the patients in the elective neck dissection cohort valued the biggest, most destructive intervention we could offer them, even if it brought more morbidity and didn't improve survival. There was a psychological benefit to them knowing that they felt they had done everything they possibly could, and the biggest operation was of value to them and important in their decision to choose elective neck dissection. Limitations of this study, obviously it's a single unit experience. You know, these were patients treated by a number of surgeons here in Liverpool. And I think what we could say, we'd expect the outcomes and the priorities to be generalizable within the UK. I think we could probably say within Northern Europe and North America. I would expect if we move to a different cultural setting, we may find differences in priorities that we haven't picked up here. Or changes in priorities as well. We always need to be aware of the tendency we all have to retrospectively validate the decisions that we made. So I always think that in retrospect, we made the right decisions. So we certainly saw that no patient regretted the choice they made, which either means everybody made the right choice or there's a bit of retrospective validation of decision-making going on. But that's just the nature of this type of research. We also need to be aware of the change with time. You know, these were late. These patients had a median time to surgery from about 2 years. So these are late outcomes we're measuring here. And I would expect if we did these interviews at different time points, we'd see flux and change in priorities over time. So to conclude, what do we learn here? Well, the worry we had was that the quality of life measures we'd been using may not reflect patient priorities. And I think that we did find that. No single quality of life measure encompassed all the issues that patients felt were priorities to them. So there's a gap in the market there. I talked to you yesterday a bit about how we could potentially fill that. I think our patient information needs to be tailored to the priorities of patients. And since doing this, we now have written a patient decision aid that addresses all these concerns and also has a section at the end that gives real-world worked examples of patients from this study, why they chose the method of neck staging that we did. So I think in conclusion, we need to keep this type of research in mind when we're designing research trials, when we're giving patients information and we're supporting their decision making, and make sure we make these patient-focused problems and not clinician-focused problems. So finally, I'd just like to thank Richard Shaw, Andrew Shackey, Simon Rogers and Lucy Frithia and the University of Liverpool for all their support and work here. And thanks for the opportunity to come and speak to you today.
Thank you, Chris. Are there questions from the audience, from the floor? No, I have some questions, Chris. You said the interviews were 2 years after the operation.
Yeah, it was cross-sectional, so we chose patients from clinic. This was the second part of a study. We ran a quantitative arm to this as well, and as part of the consent for the quantitative arm, some patients opted in to be contacted for qualitative interviews. So it was cross-section. We didn't particularly pick a 2-year time point. There was a range within that, but the kind of median figure was 2 years, with a range of about 1 to 6.
And aren't you afraid that you choose the best patients to, because some died already or didn't come up for follow-ups? There some bias?
Yeah, absolutely. So that is a risk. That patients that opt into trials may have an agenda of why they're coming in to do this, and that could be positive or negative. You know, so generally these were patients that I didn't know and hadn't treated. The patients were recruited and consented on clinic by our research nursing team. So I did take myself out of most of the recruitment there. So when it came to, when we were choosing who to interview, we needed to have an element of choosing patients. You know, we were part of the selection process to make sure we had this representative sample across the range of outcomes that we might have here. So we did purposely select them, and that's fairly normal in this type of research. But we tried to guard against just choosing the people we like.
Another question, we did, when I was in Amsterdam, we did try to do some semi-structured interviews as well, but what I learned was that some people they have to choose between one they get, central lymph node biopsy, or something they did not undergo elective neck dissection. What is your opinion, what is your experience? Because they find it hard to judge or to say something about something they have no experience with because they got the other treatment.
I think that's, I didn't talk about it here, but one of the things that was fascinating was that we had a very rarefied group here. So we had patients that had one of these interventions, so had been through the process of being on clinic, having a diagnosis, being through consent, having the procedure and experiencing it, and then being invited to a research trial and being sent, you know, all the information, and we send them out, a kind of introductory sheet saying, you know, we're going to talk about these options, and this is what sentinel node is, this is what elective neck dissection, and this is watch and wait. So they were incredibly prepared. Now, out of all the patients we saw, there was 3 that at the end of this, and at the end of spending over an hour with me, again explaining this and going through it, 3 of the patients within that group still didn't know which one of those options that they'd had. And within that setting, how valid is the consent? It's fascinating. I think some of the issues and the differences are very clear to us as surgeons, but are an entirely different world to patients. Now, we did try and address that problem in the decision aid that we made, and we made a multi-layered and multi-tiered decision aid that works at different levels. Again, another aspect we looked at within these interviews was patient information need. And we found different patients have different levels of information need, as you might expect. And some patients work on a very simple, basic, almost emotive level, and struggle to engage in understanding about differences in surgical procedures, statistical differences in survival, and any numerical data. So our introductory decision aid is very much language-based descriptions and aims to identify patient priorities rather than drill into the ins and outs of it. And through patient priority identification, see if we can steer people to the options that they want. We then have a follow-up to that gives a bit more detail about the differences in surgical techniques and what that might mean for the patients, for those that want to engage in it. And then there was a small number of patients within the study that generally had university-level education and above, that had, they were mathematically adept, that were interested in statistics and were interested in the technicalities of differences between them. So we had this extra sheet at the back that actually started drilling into numbers and stats and hazard ratios for that small group that did that. And then we finished it off with just real-world stories of, I chose Sentinel Node because the scar was shorter, and that was important to me because I work with the public, and I didn't want that. Or, elective net dissection was important to me because I wanted a really big operation. I wanted to throw the book at this. And so there isn't one answer. It's incredibly complex. But we're hopeful that this decision aid starts to work through in different layers.
Indeed, very valuable information, what patients want.
Yeah.
Thank you. Any other questions? No? I think then I want to conclude, and I want to invite you to the Dutch Head and Neck Society meeting in Hall 3A. We had Claire about image-guided surgery on sentinel node, and we will have nice presentations on ultrasound-guided, MRI-guided, and fluorescence-guided resection of primary tumors in Hall 3A. Thank you very much for the presentations. Claire, Fernandez, thank you very much. And thanks for being here.
very bright lights. So it's my pleasure to introduce Dr. Andrew McPartlin. He is a radiation oncologist at the Princess Margaret Cancer Centre and assistant professor at the University of Toronto. He, of course, did his oncology training here in the UK, including a research MD investigating the role of MR imaging in precision radiotherapy delivery. He started consultant life at the Christie in Manchester and served as the Deputy Director of the Manchester Proton Centre. But in 2022, he moved to Toronto, taking up an academic position there. His research interests include clinical trials, development of novel treatment biomarkers, and the application of precision radiotherapy to improve outcomes for patients. Thank you very much, Andrew.
Thank you. And thank you for the organising the invitation to speak today, and for those of you in the audience. I know there's a lot of great talks over the last few days on surgery and some great talks going on now, so I appreciate you making the time to attend. So I'm going to try and convince you over the next 30 minutes or so that radiation does have something to offer for the future of head and neck management. These are my disclosures that are relevant. So I just want to start talking about a case of a patient I saw recently in clinic. This is a 58-year-old guy, non-smoker, fit, young family, and kind of classic presentation, short history of adenophagia, and then more recently a neck mass. He'd been investigated, found to have a tongue-based mass and some advanced neck disease, which had been biopsy proven to be invasive squamous cell carcinoma. And on staging investigation, had evidence of mediastinal nodes and lung metastasis. The only thing in this gentleman's favor was he had HPV-positive disease, and we increasingly understand the behavior of the oligometastatic patient in this setting and the chance potentially for long-term cure, even with evidence of metastases. So after careful discussion and consent with this patient, it was agreed we would offer him definitive radical treatment to all his areas of disease. So we went on and offered him concurrent chemoradiotherapy to head and neck, and then definitive radiotherapy to lung concurrently with this. He got through this with expected toxicities and then recovered well afterwards. And I saw him last week in clinic. He's now 2 years out from treatment. His most recent staging investigations performed last month show no evidence of recurrent disease. He's back at work full time. He's with his family. So for this guy, so far a great outcome. Obviously still at high risk of treatment failure, but encouraging where we are now. But this comes at a cost. So this is his most recent MDASI that he completed when he came to clinic. So these treatments unfortunately do come with toxicity. So in particular, he's struggling with issues with dry mouth, dysgeusia, and those particularly affect his swallowing. On formal swallowing assessment, the swallow is actually not too bad. But I think largely as a consequence of these effects, he's still on a liquid nutritional supplement-only diet, and his enjoyment of food is gone. He struggles to keep his weight up. He doesn't really enjoy eating, and it does have an effect on his overall quality of life. So this is the challenge we face with our patients, particularly HPV positive. We can get very good outcomes now, but the toxicity of treatments particularly are very suboptimal. And this is borne out by multiple data series. So this on the left there, it's hard to make out, but what that is the ARTC did a study looking at patients following different types of therapy, and these were an average of 7 years after treatment. And they showed that the more intensive therapy you give, the more side effects you have. So you can see the increasing prevalence of symptoms going from surgery alone to radiation, then combinations of therapy, and finally surgery plus chemoradiotherapy is the most toxic of all of them. For most of the domains, gradually increasing, but the two I've highlighted at the bottom, xerostomia and sticky mouth, a really dramatic rise when you add in radiation therapy of any sort. So surgery patients largely avoid these symptoms or have them to a small degree. Anyone with radiation added to it suffers with a lot of side effects from this. It's one of the real areas that we need to try and address in terms of radiation treatment. And this contributes to patient regrets. So on the right there, this is showing patients interviewed following successful curative treatment. How do they feel about their treatment subsequently? And a large minority of patients, whatever modality treatment they get, express strong regret following treatment to the modality they got. Surgery, about a quarter of patients from this series. Radiation therapy, 37%. So significant numbers of patients regretting the treatment we gave them. And it's not just quality of life and how patients feel about the treatment, it's also in terms of outcome. We know that toxicities can contribute to unidentified mortality. So on the left there you're seeing series, this is from the SEER database, patients who were followed up following treatment and they were coded for having an aspiration pneumonia event following radiation therapy. And this was significant and increased with time. So at 5 years after treatment, 25% of patients following radiation therapy were coded for an aspiration event versus 9% of the background population. And if you dichotomize based on this, the overall survival dramatically different between those two groups. And this association is confirmed when you look at a per patient analysis. So on the top, on the right, there is an Australian analysis looking at patients following chemoradiotherapy and looking at cause of death. So a minority of patients dying from non-cancer related causes, and of those 20% aspiration related, so 10% overall dying from aspirated pneumonia. And on the bottom, a surgical series, patients who had oral cavity surgery and then went on to be followed up. And again, a significant proportion overall of patients dying of aspiration, and that equated to 2/3 of the non-cancer related deaths. So we know that these toxicities are a problem. What can we do about it? If you look at the treatments of head and neck cancer over the last 20 years in terms of radiation therapy, they haven't really changed. The doses we give are broadly the same. We give concurrent chemoradiotherapy. We've slightly changed the way we give the radiation therapy, but it's fairly technical. We now give the radiation the whole way through to all parts of the neck, whereas historically we used to phase it. The only thing that maybe has changed, we've talked a lot about the last few days, is the addition of immunotherapy, and there now seems to be potentially a clear role for it perioperatively, but otherwise radiation broadly unchanged. And why is that? Well, there's been a lot of work that's gone into this to try and improve toxicity whilst not affecting outcomes, and we've really struggled. Cisplatin plus radiation therapy is very good. So this is HN005 that presented at ASTRO last year. This was a very moderate de-escalation study based on a very sensible phase 2. The two investigational arms, one slightly reducing dose from 70 to 60 gray, one substituting chemotherapy for immunotherapy, and both arms had to close early because they were significantly inferior to the control arm of chemoradiotherapy, which had over a 98% progression-free survival at 2 years, so a very high bar to try and get over in terms of de-escalation. And we know that de-escalation, although we are interested in it, we know it's important for patients, we know that from patients' perspective, the priority is disease control. So this is a nice study from Canada from a few years ago, but this has been replicated by other groups. They took a group of patients who had curative treatment, and they asked them afterwards about their experiences and what they prioritized. So these patients were asked if they could avoid chemotherapy, would they? And 90% of patients, given the chance, didn't want to have chemotherapy. But immediately when he started associating that with detriment to outcome, people's responses changed dramatically. So if there was a difference between 0 and 5% in outcome, over 2/3 of patients wouldn't accept changing their treatment. And even a 1% difference or less, almost half of patients wouldn't want to change treatment for a 1% difference in overall survival. So that just speaks to the fact as clinicians, we have to be very thoughtful about any de-escalation strategies we introduce and what we think we're achieving for our patients. And there's a real challenge in terms of de-escalation and what it can actually achieve. This was a nice paper last year summarizing some of the recent de-escalation studies and looking at the MDADI score for patients before and the follow-up afterwards. And what they showed, the top line there is showing the radiation therapy alone arm from 3311, the surgery alone arm from 3311. So as has been highlighted, these patients do really well. If you can give surgery alone, no adjuvant treatment, they do very well in terms of swallow function. Probably a combination of the disease and the treatment. And at the bottom, the one that sticks out is the one that gets surgery plus chemoradiotherapy. These patients tend to do badly. We want to try and avoid it. But all the other arms in the middle, various de-escalation strategies, reducing dose or reducing adjuvant treatment, broadly within the same category. MDADI score of difference of less than 10 is considered non-clinically significant, and all of these arms within that range. So showing de-escalation to achieve clinically meaningful benefits to patient is not easy. So is there a way we can do this? Well, maybe in terms of radiation, maybe there is opportunity. So this was a great study from Chris Nutting at the Marsden, a multi-center study in the UK. And they asked a question, if you're giving radiation therapy and you're very thoughtful about the way you deliver the dose, can you improve outcomes? So for this patient group, they looked to spare the pharyngeal constrictors when they delivered the treatment. So they deliberately allowed underdosing of the elective radiotherapy volume to reduce the pharyngeal constricted doses. It was predominantly an HPV-positive oropharynx population, although it wasn't set out to necessarily be that way. So it was predominantly that group we're looking at. And they showed that by a relatively small reduction in the area you're treating, so you can see that area Get the laser working here. Just here where the dose has been taken away from the constrictors. That does actually translate into benefits for patients. So the mean dose went down, but also the use of feeding tubes was reduced between the two arms. And then the MDADI score at 1 year was reduced by 7 points by just that small reduction in dose. So not quite the clinically significant threshold to a negative study, but suggesting really thoughtful amendments to radiation therapy can have important outcome benefits for patients. And radiation therapy has changed a lot over the last 30 years. Although the overall paradigm has stayed the same, there's been a lot of technical advances, and radiation delivery is driven by technology. So there's been a lot of improvements in computing power, which has enabled radiation delivery to become much more conformal. So historically, radiation was delivered using a 2D approach. You'd have an X-ray, you'd mark on, based on bony anatomy, approximately where the tumor was going to be, and you'd apply a square beam of radiation to try and cover it. We then moved to 3D conformal, where you could have the CT scan, you could highlight where the tumor was and give a slightly more conformal plan. And more recently, RMRT and VMAT, where you modulate the radiation therapy beam as it's being delivered, or you can deliver it in an arc, which means, again, you can reduce the unintended dose to areas around the tumor whilst making sure you deliver the dose you want to the area of disease. So this paper was published in 2019, and then I'd argue there's been a couple more advances over the last few years that are going to be important in terms of patients. So we have proton therapy, which came to the UK in 2018. We have more recently the ability to do CT-guided adaptive radiation therapy, which we'll talk about, and the involvement of AI assistance in terms of delivery of radiation. And you can see here, optimistically, I'm showing the curve going up again, that perhaps these things are going to drive a further improvement in terms of how we deliver radiation in future and the improvements for patients. So, starting to talk about proton therapy, this has been an area of particular interest in the UK over the last 15 years, and even previously. Historically, we had a program where patients were sent abroad for therapy with protons. There was a few high-profile controversial cases where patients were declined to be sent abroad. They were in the press. There was a lot of discussion about whether that decision was appropriate. And in 2018, we got the national UK service, first in Manchester and then in London, which means we can now treat patients without sending away. And there's been some great stories since then about some of the benefits people have achieved in terms of protons. So if we want to talk about proton therapy, just a bit of primer in terms of what protons are actually achieving for our patients. The red curve you're seeing there is a conventional photon therapy radiation. You can see most of the dose is delivered near the surface of the skin, and then as you go further into the body, the dose drops away. Now, this is a problem for head and neck because you're generally treating central structures, so you're giving most of your dose where you don't want it. Where you need to get the dose, it's dropped away, so you end up giving more dose overall. Proton therapy has the ability instead to deliver little dose near the surface, and then towards the end of its range, there's a peak of dose where it's delivered where you need it, and then it drops off very quickly. And what that means, if you look on this curve, is these two red areas are where the dose would have been delivered with photon therapy, but they can be spared with protons, so giving an opportunity potentially to reduce toxicities and improve outcomes for patients. And if you look at the CRUK page on proton therapy, they've got a nice diagram, and it kind of describes this. They say, if you use conventional therapy, you give all this radiation beyond it, which you don't want. If you give proton therapy, you can stop and you just treat the tumor, which is great. But unfortunately, it's a little bit more complex than that. And the reason for that is that proton therapy planning and delivery is actually very complex. The modeling of it is very challenging, and there's a lot of uncertainty in the way it can be delivered. And this uncertainty contributes to a reduction in the conformality we can achieve. And the two major uncertainties, one is each day the patient will set up slightly differently. So you have to allow a few millimeters for that potential setup variation each day. And the other uncertainty is that protons, as they travel through the body, are affected by the tissue that they travel through. So again, that setup variation means that day by day, you can't exactly calculate where the proton is going to stop and deliver its dose. Now, for conventional therapy, it doesn't really matter too much. We see the curve on the top. There's not that much difference based on the setup. But this peak, if it moves, if you're near a structure like the brainstem, for example, instead of dropping your dose off down here, you end up giving dose up here. So you can cause a lot of unexpected toxicities which have to be accounted for. And what that means is you plan for robustness, and you have to account for these potential worst-case scenarios in your plan, which ends up affecting the confidence with which you can deliver it. And what you end up with proton therapy generally is something like this. So you do spare a lot of dose. You can see on the left-hand side here, conventional photon therapy, the higher dose, the red, going away to the blue dose further down. With proton therapy, you lose a lot of this low-dose wash, which is fantastic. You can do a lot in terms of reducing the dose to patients, reducing toxicity. But if you look here around the high-dose area, actually very similar between the two. The conformality around the high-dose area of protons, there's not a great deal of difference generally, so it's not there necessarily that you're going to see the benefit for your patients. And then the other issue with proton therapy, beyond the issue with conformality and the challenges with planning, is that we know there's unexpected or can be unexpected effects. In proton therapy, the way the energy is delivered is somewhat unpredictable. We know that for a given dose, proton therapy has more biological effect than photon therapy, which we account for. We apply a correction factor of 1.1 for a given prescribed dose. But beyond that, we also know that the RBE, the relative biological effect, isn't constant. As the proton slows down towards the end of range, it tends to deliver more energy than would be modeled for. And this is due to something called the linear energy transfer effect. Now, this is challenging because you can't measure it directly and you can't know exactly where that's going to be. You can model it and you can make some reasonable estimations, but it isn't something that's easy to directly measure. You can harness this. This can actually give a benefit to patients in terms of the way you deliver those. So if you have areas within the tumor where you're most concerned about disease control, so for example, within a tumor, if you have the ability to identify a hypoxic subregion, we know as radioresistant, you can use this feature to exploit that and deliver more energy to those areas whilst delivering less energy to areas around it. But the other major issue with this is it can potentially be associated with unexpected toxicities to nearby organs at risk. And this is something we don't fully understand yet, but it's something that's certainly seen in studies. So this was a nice piece of work done by Memorial Sloan Kettering. They looked at patients post-proton treatment or post-photon treatment, and they looked at their PET-CT at 12 weeks after therapy. And these were patients who were cured of their cancer. So this avidity wasn't related to persistent cancer. This was other changes. And they hypothesized that these areas of avidity on the PET-CT scans were related to mucosal toxicity from the radiation therapy, and they would correlate to late effects for these patients. And what they showed, as you see on the table on the right, is that there was a significant difference in terms of the SUV max for patients who got proton therapy versus photon therapy, with higher SUVs in the proton therapy group, suggesting that perhaps due to this end of range effect, we're actually seeing more damage to these patients from the proton therapy in terms of OAR toxicity in that high dose region than with the proton therapy. So photon therapy. So certain things to be concerned about there and potential unexpected effects from protons. So what data do we have to reassure us that these treatments are giving benefits to patients? Well, historically, the data for proton therapy has been somewhat limited due to the way that therapies have been set up in the United States. The majority of centers there have been set up to run privately, to treat patients with insurance cover, and not been motivated to run trials. So although there's been 20 years or more experience treating head and neck cancer patients, the reported literature until fairly recently has been quite scant. So this was a study from UPenn that was published in 2018. This was patients who received TORS therapy and then had adjuvant proton or photon treatment. This wasn't randomized, so there's selection bias in terms of which patients went on to receive proton therapy. But what they showed that was there was a significant difference in terms of doses. They reported the parotid doses significantly spared by giving proton therapy, and that translated into a benefit in terms of xerostomia rates at 6 and 12 months, and patients feeling better in terms of their overall quality of life, so suggestive of benefit for that group. And then MD Anderson, a couple of years later, published a series from their center, relatively small numbers, 71 patients, with oropharynx treatment, giving primary chemoradiotherapy, predominantly HPV-positive disease, and they had repeat MDADI scores performed before and then after treatment. And what they showed following proton therapy was there was a pretty good recovery of scores. They started at a baseline of 90, and by 24 months, the MDADI score was up to 82, and there was only a 2.7% feeding tube dependency rate, which again compares well to the literature. So pretty encouraging for proton therapy, but as commented by the paper itself, the trajectory in terms of what they achieved was actually pretty similar to what they would expect to get with photons. So not a clear-cut win there for proton therapy for these patients. Most recently, we've had the best data for proton therapy. So this was presented last year at ASCO. So this was a randomized phase 3 trial for patients with oropharynx carcinoma. This was run from MD Anderson, but multi-center in the United States. And these patients were randomized between proton therapy or photon therapy with chemotherapy for their oropharyngeal carcinoma. So 444 patients received treatment, 221 patients in the proton arm. The median follow-up at the time of reporting was just over 3 years. It's important to note with this report, they reported this in various ways. There was the intention to treat arm, and then there was the treatment received per protocol, and then there was the actual treatment received. So treatment received per protocol was actually just under 300 patients. So about 2/3 of the patients in the study, treatment received per protocol. There's confounders in terms of why they wouldn't have received treatment, and probably one of the big confounders is patients who were randomized to the photon arm but could afford to pay for proton therapy may well have deselected out of the study. So you have to consider that when you're looking at the results that are reported subsequently and how that might bias the results that have been seen. But when they reported the results from this trial, some really encouraging results. On the bottom there, the use of feeding tubes during and after treatment, so a clear reduction in terms of feeding tube rate from the use of proton therapy, going down from 42% in the RMRT arm to 28% in the proton arm. There was some discussion in the community about those rates and whether 42% for RMRT would be considered within the expected range nowadays, but I think it probably does fit with a lot of people's experience in terms of feeding tube rates. But the other interesting finding they had was that actually it was powered to look at non-inferiority in terms of outcome for patients, but what they showed was maybe a suggestion in terms of overall survival of benefit. So 3 years out from treatment, almost a 10% survival difference between the two arms. So their conclusion from this was that proton therapy was non-inferior, reduced toxicity, and could be considered a standard of care. And then they updated these results at NAPT this year, and that survival benefit at 5 years has slightly expanded to 11% and is now statistically significant. So a really interesting finding, but the correlate to that, the progression-free survival between the two arms is the same. So the question is, why are we seeing that overall survival difference with protons? You could argue, if you're a believer, that toxicity contribution to unexpected deaths, maybe that's reduced with proton therapy and we're reducing some of that, and that's why we're seeing a survival benefit. Or it may just be something related to the randomization between the two arms. So we have the Torpedo trial, I think, is reading out. The UK proton study is reading out at Astro this year. So if that confirms some of these findings, it really will be exciting for the group, or it may raise further questions in terms of how we apply this. And then in terms of surgery and proton therapy, this is a headlight study looking at oral cavity carcinoma, adjuvant proton versus photon therapy. They published some data looking at the comparative dosimetric outcome, and they showed that proton therapy in oral cavity postoperatively can also deliver significant benefits in terms of OER reduction. Statistically, whether these are clinically significant, we'll have to wait and see for the outcomes, but perhaps suggesting a role for proton therapy in this group. And then proton therapy is an evolving space. So currently the treatment for it is relatively crude in terms of fixed beams that treat the patient. We use arc therapy for photon therapy. This will be coming for protons soon. And this was a recent paper. There's a lot like this showing that with arc therapy, we're going to be able to improve the sparing. This one's showing that the proportion of patients with significant benefit in terms of grade 2 or higher toxicity is greatly improved by having the arc therapy approach. So again, opportunities to leverage for proton therapy treatment. The other piece I wanted to briefly talk about in terms of radiotherapy, if we can deliver the radiation more conformally using protons, is there a way we can improve our target and reduce the volumes we're treating? For radiation therapy, currently, we have to account for various things. We have to account for the tumor, the GTV. We have to account for uncertainty, similar to a surgical margin around the tumor, or CTV. And the final thing, we have to account for uncertainties in terms of where the tumor is going to be each day, the PTV, which includes things like motion during treatment, how the patient sets up each day, and then changes in anatomy during therapy. And what that means is the area we're treating, the tumor, goes from around 15 centimeters as an example, and it quadruples in size in terms of volume we're treating when you add in these uncertainties to it, with the consequent effects in terms of toxicity for patients. And then you add in things like elective neck volumes, you end up irradiating large volumes of the patient's head and neck, with consequent detriment to their overall outcomes. And these have consequences for them. This is a study from Belgium where they did sequential cohorts when they changed their approach and reduced their PTV margin based on improved setup. And going from a 5 millimeter to a 3 millimeter margin, so very small changes, they showed that their rates of grade 3 dysphagia dropped dramatically, their rates of feeding tube dependency at 3 months were halved, and they could maintain their local control. So again, showing that very thoughtful radiation changes can contribute to meaningful effects for patients. But we know there's uncertainty in terms of what we're treating. This is a series from MD Anderson looking at patients with repeat MR scans during treatment and looking at tumor response. And they were looking at whether FDG PET at baseline could predict for these changes. But what they showed was that for all of the patients, there were significant changes in terms of the overall volume. And then for the patients with the highest avidity, the ones who responded most, by 3 weeks, the overall volume of tumor had approximately halved. So the area you were planning to treat at the start of therapy had halved by week 3, and they still had another 4 weeks to go of treatment. So there's an opportunity there to rationalize what we're doing. And not just the tumor, the other things that change are OARs. We know the parotids and the submandibular glands move during treatment. They shrink, they move medially. This is a patient scan at week 1 and week 5 showing dramatic changes with weight loss and changes in anatomy you can see. And this again means that what we think we're targeting at the start of therapy can actually be very different to what we're treating towards the end of the treatment. So how do we account for that? So currently, and historically, the approach has been to have a plan that's fairly robust to all these changes, which means necessarily it's less conformal than it can be. So the line on the top there showing you create a plan at week 1, you carry on the plan the whole way through, and the patient has the same treatment each day. An alternative approach, which has been investigated over the last 15 years with multiple studies, is a potential benefit from doing replans during treatment. Now, these can be at various intervals, once or more, and see whether those improve benefit. And there's been a lot of retrospective, non-randomized studies comparing these effects, suggesting potential benefit for them. And then the most recent possibility is daily online adaptive, where you actually create a new plan each day for patient on the unit, and that's permitted now by increased computing power and AI, and we'll just talk briefly about that. So in terms of repeat replanning during treatment, this is a very labor-intensive study performed in France. So they did weekly replans of patients during radiation therapy. The primary focus was trying to spare parotid doses. This was for a group of patients with oropharynx disease, stage 3, stage 4. They had replans every week during therapy versus a control arm that allowed up to 1 replan. And what they showed was it didn't achieve any meaningful difference. So these patients, despite the huge amount of labor that went into it, there was no clinically difference in terms of xerostomia rates at the end of treatment. There was a suggestion, perhaps in terms of flow rate, a slight benefit, but nothing that would justify the increased workload and cost from this sort of non-selective repeat adaptation during therapy. It has to be acknowledged the other arm having a single adaptation. That may have confounded somewhat because data does suggest perhaps 1 replan during treatment gives most of the benefit you're going to achieve by this replan approach. And if it doesn't improve OAR sparing, what can this offline adaptation achieve? Well, maybe it's more in terms of target coverage. This was a study published this year by David Shearer and the Texas Southwestern group, and they showed by replanning up to 3 times up here, the target coverage can be greatly improved. You can get unexpected cold spots in tumors if you don't replan that you wouldn't be aware of. And if you replan, you can improve that. And perhaps that might contribute for a minority of patients to prevent local recurrences. But the big area of interest now is online adaptive treatment. There's a number of units with MR or CT-guided technology that can allow you each day to bring the patient to the unit, perform a scan, and then rapidly recontour all your structures using AI computer guidance, and then generate on the fly a new radiation plan over a few minutes, which can then be delivered. So this is potentially can revolutionize the way we deliver radiation therapy for patients, harnessing this technology. But the question is, does it deliver any meaningful benefit for our patients? So there's one randomized study looking at this, and I just want to caveat it first by describing their approach. So this is the Southwestern group again, and they've pioneered an approach generally for their head and neck radiation therapy, which is fairly provocative. So instead of treating the entire neck with elective radiation therapy, which you see on the top there, they've pioneered an approach instead where they identify all the nodes using various criteria and also using an AI model to pick out nodes of concern. They treat those nodes alone. They don't treat the rest of the neck, so hugely reducing the volume of neck needs to be irradiated. So this was a study just looking at that approach, what happens when we reduce the neck volume. And they showed it gave significant potential benefits compared to historic data, single-arm study, but they showed the G-tube dependency rate 21%, so lower than both arms of the proton-photon study. And the MDADI scores at 12 and 24 months from this approach, 89 and 93. You compare that to the curve we looked at earlier on, you see that's up there with the surgery alone arms, so showing these reduction in volumes again, maybe can get us improved outcomes for patients, but non-randomized. So this approach was then applied in adaptive therapy, so a really high bar to be trying to get over. So they used this approach, and they used daily adaptation for half of the patients, where they reduced the margin around those involved nodes and around the primary target from 5 millimeters to 1 millimeter. And even in this really high bar cohort, they did show a benefit from daily adaptation. They showed they could reduce the doses by doing this. The central structures weren't spared. This is more the submandibulars and the parotid glands. The pharyngeal constrictor dose is unchanged, probably because of the small volumes we were treating in both arms. That led to a reduction in greater than grade 2 mucositis. So a third of patients in this study getting chemoradiotherapy had grade 1 or grade 0 mucositis, which is a really amazing outcome compared to what we generally see with our patients. And then that led to a trend in benefit in terms of xerostomia, not quite reaching the clinical significance, but a trend to suggesting benefit even for this patient group with the 2 hard arms. But the big issue with it was that mean treatment time was 39 minutes, so very labor intensive to deliver. Is that plausible to have this with a clinician at the unit each day to recontour the structures? So perhaps the answer is more targeted treatments. So this is looking at xerostomia, which is a big measure we talked about to try and improve. On the left, there's a curve for patients who received surgery and adjuvant radiation therapy. And we show that if you get bilateral neck, you get very severe xerostomia. Unilateral neck, less, and it recovers well. No neck, they do the best. So again, speaking to the volume reduction being important for reducing xerostomia rates. And we know that for the submandibular gland, it's very sensitive to dose. So if you can reduce the submandibular gland dose, you can spare xerostomia and improve things for patients. So a great target for adaptive radiation therapy. And there's a very high dose gradient across the submandibular. So we've done some work looking at this, and by doing adaptive radiation therapy and reducing the margin, focusing on this area, you can more than half the dose to the submandibular gland, get down to the sort of doses less than 20 gray that we think will translate into meaningful xerostomia benefits for patients. And the great thing about that sort of approach is you don't need a clinician to do that. That is image guided. That's something that radiation therapists can do. So we're opening a study shortly in Princess Margaret, funded by Varian, where we're looking at these reduced margins around the salivary glands. It's been led by one of our radiation therapists, Devon Hindle. He's done some fantastic work training the radiation therapists to do this approach. And this may be the future of adaptive radiation therapy, very focused, radiation therapist delivered, quick treatment times, clinician not required, potentially scalable for routine treatments of our patients. So going back to our original curve, I would suggest we're somewhere there at the bottom with potentially an opportunity for this to dramatically improve over the next few years. And I would hope with the application of this improving computer technology, ability to deliver more formal radiation therapy and application of AI techniques for patients like Mr. Dunnett in future, the outcomes in addition to disease control will be improved toxicities. Thank you.
Thank you, Andrew. That was a really comprehensive talk on the possibilities, I guess, and pitfalls of radiotherapy future directions. We now have a couple of free papers. So our first presenter is Amit Ritter. Is Amit here? So Amit is going to present his abstract on predicting individual response to postoperative radiotherapy in oral cavity squamous cell carcinoma. Thank you.
All right. So, good morning, everybody. I'm Amit Ritter from the Rabin Medical Center in Israel. And today I'll present a tool we developed during my fellowship time at Memorial Sloan Kettering to predict the response of oral cancer patients to adjuvant radiotherapy. I have no disclosures. And when I consider the benefits of adjuvant radiotherapy, I wonder, does more always mean better, or can it sometimes be unnecessary? I can't help but wonder, why do patients relapse after adjuvant therapy, and how many of them are not going to respond to adjuvant therapy and therefore receive unnecessary treatment? And perhaps the ultimate question is, can we identify patients who won't benefit from adjuvant radiotherapy? So we're all familiar with the NCCN guidelines for oral cavity. And when you look into the guidelines and the factors guiding our decision whether to give postoperative radiation or not, you realize it could affect a lot of patients, those in advanced stages and some in early stages with different adverse features. And generally, as surgeons, we tend to stick to the guidelines, believing they're based on solid evidence. But we at Memorial decided to dive into the data and review the literature. Now, obviously, for the sake of time, I won't review all the literature on postoperative RT for oral cavity cancer, but to make it brief, the literature largely relies on retrospective data and extrapolates radiotherapy benefits from other surgical fields, looking historically. And in fact, I could find only 2 RCTs on postoperative radiotherapy for oral cavity cancer. And therefore, we concluded a large randomized controlled trial is ideal, but my fellowship left me racing the clock, and spoiler, I lost. So instead, we decided using a large cohort of patients to develop an advanced prediction tool for radiotherapy response after surgery. So over 2,000 patients treated for oral cancer with at least 2-year follow-up, we identified 737 patients who received adjuvant radiotherapy. And we then divided them into 2 groups, those who responded well to treatment and those who recurred within 2 years. And looking at the recurrence group, we had a total of 195 patients with recurrent disease within 2 years, which accounts for approximately a quarter of the cohort. Here you can see the Kaplan-Meier curves for recurrence-free survival and disease-specific survival. And then we really turned into 2 statistics. So first, we used an imputed missing data model to estimate and fill in missing values by predicting them from existing data. And that allowed us to retain all available data for analysis, improve statistical power, and reduce bias. Next, we compared between the 2 groups. So we used univariate and multivariate analysis to identify significant factors that differentiate between patients who responded well to surgery and those who recurred. And as you can see here, univariate analysis showed similar demographics, but recurrence was associated with higher perineural and lymphovascular invasion, as well as nodal metastasis and extranodal extension. And remarkably, the resection margin status was comparable, but I guess this is a topic for a whole different conversation. And then we turned to multivariate analysis, which identified key predictors for the nomogram. Interestingly, the heart palette emerged as a subsite significantly associated with recurrence. So next, we developed a nomogram, which is a visual tool that helps predict the likelihood of a certain outcome. And, okay. All right, now, relax, I'm not about to throw around terms like regression models or beta coefficients or inverse link functions, but basically we used the factors found to be significant in the multivariate analysis and assign points based on the strength of their associations. And our algorithm then assigned points to each factor to create this calculating tool. And let me show you an example. Imagine a patient with a buccal mucosa tumor, highlighted in red on the visual tool. The tumor stage is T3 and 0, no perivascular invasion, but significant perineural invasion. Neutrophil to lymphocyte ratio is 2, and each factor is assigned points, which are then summed up as shown in the green circle to estimate both 1-year and 2-year recurrence-free survival. And in this case, the estimate is approximately 80%. So finally, we conducted an internal validation to assess the accuracy of our tool. And internal validation was done using bootstrapping, which involves creating multiple new data sets by repeatedly sampling the data. This helped us ensure the model's results were reliable. And let me demonstrate. Using bootstrapping, we randomly select patient records, allowing repetitions to form a new data set. And this allows us to test the nomogram on different samples and check its performance. And in our study, that was done 1,000 times to enhance reliability. And here you can see a calibration plot demonstrating a strong correlation between the actual and predicted recurrence-free survival. And without getting too much into details, that basically means this nomogram was successfully validated. And the final outcome is a validated predicting tool to assess survival in patients who are candidates for adjuvant therapy after all cancer surgery. So to conclude, we have created a tool to predict recurrence-free survival in patients with oral cancer treated with both surgery and adjuvant radiotherapy. This tool has the potential to tailor recurrence risk estimates to the individual patient, and it may also guide follow-up intensity, systemic therapy choices, and trial enrollment. This nomogram provides a consistent evidence-based tool for tumor boards and treatment planning. And finally, this study lays a groundwork for identifying which patients benefit from adjuvant radiotherapy. And in that, I conclude my talk. I would like to thank the team at Memorial Sloan Kettering, and especially my mentors, Dr. Ian Ganley and Dr. Snehal Patel. Thank you very much.
Thank you very much. That was really interesting and potentially useful, I think. Any questions from the audience? Can I maybe start by asking if you've got any plans to externally validate the work that you've done?
Yeah, that's an excellent choice. We are setting a multi-institutional study for external validation, at least 2 other external other institutions that are collaborating. Yes.
Okay. Andrew?
You mentioned the challenge of understanding the benefit of adjuvant radiation. Right. Is there any ability to use this data set to estimate the benefit of adjuvant treatment?
So as I showed, all the patients in the current cohort were treated eventually with radiotherapy. So this was biased towards just estimating how they're going to respond. We do have a different set of patients who had indication for radiation but did not receive radiation for various reasons unrelated to indication. And we are looking into that now, and hopefully within a year or 2, I'll be able to share this data as well.
Okay, thank you very much. Our next free paper is Andrea Constantino presenting on machine learning-driven risk stratification and adjuvant treatment guidance in oral cavity cancer.
So, good morning. I think I had the same questions my colleague had before me. So, when do we really need to do adjuvant radiation and adjuvant chemoradiation? And I try to use a slightly different approach. As we all know, oral cavity is a surgical disease, so we treat patients with primary surgery all the time. And we base our decisions in performing adjuvant treatment based on these adverse features. And these adverse features are based on whole studies, these 21 years old trials that we all know, and the same features that were used at that time are the features that we use today. And here there's a distinction between high risk, intermediate risk, and low risk, with positive margins and external extensions being high risk and all the other patients being in intermediate risk. This is a whole paper employing a similar approach to the one we just saw. So it's a multivariable Cox regression with constructing a nomogram. Here there's no the image of the nomogram, but this is the value of each feature that was included in the final model. And in this case, the study was actually done at Sloan Kettering, Toronto, and I think São Paulo, Brazil. In this case, adjuvant radiation was included in the model, and in this way, they were able to distinguish the survival based on the delivery of adjuvant radiation. So in this specific example they provide was with radiation, we have 22% survival at 5 years. This case was local regional recurrence-free survival. Without radiation, 11%. So they, these are an extreme case. So I would say we will recommend radiation. This is another example of a T2 and 0 buccal cancer with or without radiation. We try to use a machine learning approach, so a different statistical model, and as we all know, this is a trendy approach now, and theoretically, the benefit of this approach is to have a better understanding of the importance of each variable in a big data set, in a large data set, using clinical and pathological features. And these are the 3 specific models that are used in this study. They all have different structure, and they all have used different algorithms to give the final prediction for each patient. And in this specific study, of course, the aim was to stratify patients in low risk, intermediate risk, and high risk, and guide adjuvant treatment based on that. So theoretically, low risk, no adjuvants; intermediate, only radiation; high risk, chemoradiation. Data were retrieved from the United States National Cancer Database, and we included all oral cavity patients treated between 2010 and 2021, only squamous cell, and all patients underwent primary surgery with neck dissection with at least 18 lymph nodes examined. We excluded patients with unknown pathologic features, so we did some imputation of missing data, but not for the main pathologic features. All patients with previous radiation were excluded, and of course, palliative treatment. In terms of methodology of the work, the main thing, in my opinion, is that for the study I showed from 10 years ago, was that including radiation in the model doesn't really help you in defining if the patient needs radiation, because radiation will, in some ways, alter the effect of each other variable, pathological variable. As we said, the margin status, for example, before, it seemed to be not really powerful because of radiation. So the model was trained only with patients undergoing surgery alone. And the total cohort of patients was more than 35,000 patients, so of course big numbers. 18,000 underwent surgery alone. And this cohort was split in 70 and 30%, 70% for the training and 30% for the testing, so to evaluate the accuracy of the model. But then to define if the patient really requires a benefit from adjuvant radiation, the models were applied to the entire cohort. What variables did we use? Demographic variables: sex, race, age, probably most important. Socioeconomic variables: insurance status, important in the United States, and area of residence. And mainly, of course, clinical variables. I would say that the only variable that is usually used for adjuvant treatment decisions, delivery decisions, is the PNI that is not available in the NCDB, and hospital factors. So this is the evaluation of the accuracy of the models in the testing, so in the 30% of patients undergoing surgery alone. The C-index was similar between the 3 models. And you can see here the 2 curves. The red curve is the actual survival of the patients, and the blue curve is the predicted survival. And you can see there's a good match between the 2 curves. Then the models were applied to the entire cohorts. These are the stratification in low risk, intermediate, and high risk, and this is the first result. Of course, the models are able to distinguish patients in terms of survival, and in this case, the primary outcome was overall survival. In general, patients were, overall 50% of the patients were stratified in the low risk group, a bit less in the last model, 38, and around 18% of the patients were high risk. This is the survival that you can also, of course, see from the curves. And if we look at the specific models and how the groups defined by the models survived, depending on the treatment, we can see for the deep serve model in this case, for example, low-risk patients having similar survival, slightly better with surgery alone. And we can assume these patients don't need to receive adjuvant treatment. Intermediate risk, there was a higher survival in case of adjuvant treatment with no difference between adjuvant radiation and chemoradiation. And lastly, high-risk group, adjuvant chemoradiation had a slight advantage compared to radiation, around 5%, but both were definitely better than surgery alone. I also did a Cox multivariable regression to adjust for other features, and the results are pretty the same. This is the second model, and there was no real difference compared to the previous one. Again, surgery better in low risk, surgery with radiation in the intermediate risk, and chemoradiation in the high risk. Again, Cox regression, similar results. And if you want to look at the like hazard ratios, here there's no really difference between the treatment. Here there's benefit from adjuvant treatment with no difference between chemoradiation and radiation. That is slightly evident in this in the high-risk group. This is the last model. Similar results, I would say this model had less percentage of low-risk patients, 38 compared to 50%. So in these terms, maybe this model has a less, is less efficient in stratifying patients. This is, I would say, speculation, but this is the final goal. So the blue curve is the curve for the entire cohort, and the 5-year overall survival was 61%. The other three curves represent the models, the three models, and the patients included in these curves are just the patients that receive the appropriate treatment based on the recommendations. So low risk with surgery alone, intermediate with adjuvant radiation, high risk with adjuvant chemoradiation, and these are around 60% of the cohort for all three models. And you can see there's a benefit of around 7-8% compared to the surgery alone group, and compared to the entire cohort. So overall, this is the final goal. So we want to use the machine learning models to give guidance for delivering adjuvant treatment, and the goal should be to increase survival and maybe reduce functional impairment, sparing adjuvant treatment if not needed. How machine learning is different compared to a Cox regression? It's really complicated, and no one really knows what's happening inside the algorithm. This is one of the things that we can retrieve from the models, and while in the Cox regression we have the hazard ratio, that is a number that we can use to compare the impact of each variable in the model. Here we have a permutation feature importance score, and this is the list of variables that are more important in each model. And as you can see, the three models are slightly different, but similar, like PT4, E&E, advanced stage are the most important variables in almost all of them. So overall, the use of machine learning is feasible, of course, to stratify patients, and might be associated with a clinical meaningful benefits. The goal is to tailor adjuvant treatment, and the goal is both to avoid overtreatment if the patient doesn't need adjuvant radiation, or to escalate treatment in high-risk patients delivering a higher dose of radiation and chemotherapy. And of course, this is a preliminary study, used NCDB data, this like a large retrospective data set. We need a prospective validation. And the main other thing is that other variables can be used, and this might be a benefit of machine learning compared to the Cox regression, because having larger amount of data, using machine learning, we can use a larger amount of variables, genomic, radiomic, and other data. And of course, this has to be compared to the standard of care, as I showed in the last curve. And we need to expect a higher survival using machine learning if we really want to use it. Thank you.
Thank you very much. Really impressive patient numbers that you need for this kind of work, I think. Any questions from the audience? Can I start by asking, was there any factors that the algorithm threw up that were unexpected that you perhaps wouldn't have thought of including clinically, or that we consider day-to-day clinically for adjuvant treatment?
So for variable selection, it was done basically on the variables that are available in the data set. So for example, for socioeconomic variables, I excluded some variables that were not, in my mind, important for the prediction. And in the end, all the variables I shown in the table were all included in the model. And this is a sort of benefit compared to the Cox. Cox, there's a selection of variables, and like in the normal we saw before, there are 5, 6 variables included. And maybe with machine learning, with these numbers, adding more variables can increase the accuracy of the model.
Okay, thank you. Any other questions? Nope. Okay, I think we'll wrap this session up. Thank you all for coming. Thank you to our excellent speakers.
Analysis, please.
Can you see that? There's another one right here. Play, please. Okay, can you see that? Nice, and follow me again. Scott, can you see this?
Cajun, I like Cajun.
Okay, you see that? Acetone, curved periosteal, ready. Yeah, Prius.
Another one? You good? No, just a little bit. Okay, now. Can you see that? Right? So now I'm gonna like that. Can you see that? Good. So what?
Recording it.
And then I'm gonna go in here.
Perfect.
make that film you can get on your way.
It's good.
Small plate.
Shall Becker, 5,000 units, March 18.
Let's do that one more time. Ready?
Okay. White line, please. Let me see what I took out.
Seems like a little bit. Okay. Good morning to you all. My name is Thiago Oliveira. I'm a medical oncologist from AC Camargo Cancer Center in Brazil. We're going to start our joint society symposium hosted by the Brazilian Group of Head and Neck Cancer and the Brazilian Society of Head and Neck Surgery. So I'd like to invite to moderate this first discussion, Dr. Fernando Valder, to join the stage. Milena unfortunately couldn't come, so Fernando's gonna moderate this table. So I'm just gonna invite our first speaker is Dr. Aline Lauda. Aline is a medical oncologist from Dom Oncologia and Oncoclínicas Brazil, and she's gonna talk to us about the increasing incidence of oral cancer in individuals aged 70 and older. Aline?
Hello, good afternoon, good morning, good afternoon. It's an honor to be here with you to talk about increasing incidence of oral cancer individuals aged 70 and over. These are my disclosures, non-related with this presentation. This was an image generated by ChatGPT, and this presentation will focus on the epidemiological trends indicating a surge in head and neck cancer cases among the elderly and discuss potential contributing factors. Yeah. The first question is oral cancer really increasing in older adults? We have three factors we need to discuss. The epidemiological evidence, that population-based studies in multiple countries confirm a consistent increase of 2 to 3% per year in the incidence of oral cancer in individuals aged 70 plus years over the last 2 decades. And we need to discuss about demographic factors. Population aging contributes to the absolute increase in cases, but age-adjusted rates also show significant growth. And diagnostic bias, because improved diagnostic techniques and increased vigilance only partially explain this observed increase. Let's talk about numbers. Worldwide, head and neck squamous cell carcinoma, the annual incidence is over 800,000 cases per year, and mortality more than 400,000 cases per year. These figures summarize the global burden of head and neck cancer from 1990 to 2019, with an increase in age incidence rate, most of them because of women increase. And we have a decrease in age death rate. This projection to 2040, we have a younger patient who have an increase in 22%. This is a Gemagata from Milan publication. And older patients, we have a projected increase of 79% in 2040. Taking into account only oral cavity, the data from Global Cancer Observatory, we have an increase of 53% in 2045. This is a projected higher incidence, but this is the historical trends from 2000 up to 2020. Older patients older than 70 years, an increase of 57%, and 6 to 69 years, an increase in 21%. This data can see, this increase can also be seen in SEER data in all ages of oral cavity. We have this line, a red line, and age 65 plus, this light purple line, in this increase here. If you take age 65 plus, we can separate this pink line, and 75 plus, this orange line. And it's important to point that this increase, the higher proportion here in orange, 70 plus years, is in higher, in countries with higher social demographic index. So about the question, is oral cancer really increasing in older adults? Yes. We have these epidemiological trends, 1.5% increase per year in the incidence in people aged 70 plus, a greater increase than in other age groups. But the largest increase is reported in Europe and North America and in high-income countries. And there is significant variation between different geographic regions. And who are these patients? And when we check the papers, we can see that there is a male predominance, but recent upward trend in older women, 15% in the last decade, a mean age diagnosis of 78 years, a high proportion of patients living alone, with a lower average socioeconomic status compared to older age groups, an average of 3.2 comorbidities per patient, the majority of them with advanced states compared with younger patients, and the most frequent suicide is strong, 42% of cases. The risk factors associated with these elderly patients is long-term exposure to carcinogens, immunological change, and, of course, genomic instability. If you take these key drivers that contribute to this rise in incidence in elderly, as I mentioned, lifestyle factors, environmental factors, but I would like just to point to about cancer biology and age. And age comes with DNA damage, inflammation, epigenetic changes, and all of these factors are associated with age and oral cancer. And this is a very interesting paper about aging, hallmarks of aging, and the correlation, the hallmarks of aging and the hallmarks of cancer. And several hallmarks of aging, for example, genomic instability, epigenetic alterations, chronic inflammation, dysbiosis, are very similar to specific cancer hallmarks, while other features of aging, as telomere attrition, stem cell exhaustion, probably are antagonists to this process of carcinogenesis. And this article developed this model, proposed this model of meta-hallmarks, hallmarks that is in common with aging and cancer, and the antagonist factors, ambivalent factors, tumor-promoting factors, and metabolic commonalities. And finally, why is oral cancer increasing? What else you can say about that? The extended life expectancy, compromised oral health, multimorbidities, and of course, immunosenescence. And there are many challenges. Cancer prevention and detection in older patients is difficult because of fewer procedures of diagnosis and staging, fewer therapeutic intervention in subgroups of patients, less appropriate treatments because of numerous comorbidities, poor performance status, and polypharmacy. And many times, physicians may hold stereotypes, adopt a pessimistic therapeutic approach, and lack knowledge about normal aging leading them to prescribe alternative or less curative treatment methods. In conclusion, this is what we have here today. We have these trends, increasing incidence in head and neck squamous cell carcinoma, not only for older patients, but the strongest rise in patients over 70 years, a higher increase among women, more pronounced in high-income countries, and there is a large geographic variation. The underlying factors, long-term carcinogen exposure, immunosenescence, and genomic instability, and of course, is aging and cancer meta hallmarks. Why it matters? As life expectancy rises and the demographic shift towards an aging society accelerates, it's crucial to gain a greater understanding of the epidemiological patterns and risk factors associated with cancer in older adults to develop effective preventive strategies and optimize care delivery. I think this is my final message, and I thank you for the opportunity. Yes.
Thank you, Aline. We're gonna reserve the questions to the end of the session. I would like now to invite Dr. William. He's a medical oncologist, also from Brazil, from Oncoclínicas. He's gonna talk about the therapeutic decision-making in geriatric patients. Dr. William.
Thank you very much, Thiago. Good afternoon. So my task is to discuss the therapeutic decision-making in geriatric patients, and the topic of my talk is navigating limited evidence. And indeed, as I reviewed it, it is true that there is very limited evidence on what we should do to treat these patients that are older than 65 or 70. Here are my conflicts of interest. And as a matter of fact, the issue is even complicated when we go to the elderly definition. So 65 years is a commonly accepted age to define elderly individuals in high-income countries, but the United Nations, for example, defines elderly patients as those above 60 years of age. And the National Institute of Aging at the National Institutes of Health define elderly as young old if the age is between 65 to 74, older old if it's 75 to 85, or oldest old if it's above 85. And there has been a rising incidence with the global aging, as we just heard from Dr. Aline Lauda. However, even though we do see a higher incidence of head and neck cancers in patients that are elderly, there is underrepresentation in clinical trials. So patients that are less than 65 years of age comprise about 49% of the head and neck cancers, according to the SEER or real-world data, but they represent 67 to 75% of the patients that are included in clinical trials. Those patients that are above 70 years of age represent about 30% of all head and neck cancers, but they only represent less than 5% in treatment trials and 25% in observational cohorts. So indeed, there is a discrepancy between what we see in our day-to-day practice and the patients that have been included in clinical trials on which we base our therapeutic decisions. There's also the issue of chronologic versus biologic age. This is completely different. The chronologic age may not be the same as the biologic age, and this differs in terms of treatment tolerance. And we normally would use comorbidity, frailty, ECOG performance status, or cognition to try to understand what the biologic age of our patients are. There are several geriatric tools that can be used for head and neck cancer care, and this just confounds a little bit more the literature because there's not one single tool that's been considered the standard one to be used in terms of stratifying patients in clinical trials. Let's go through some of the literature that tries to get into what the benefits of common treatments are in patients that are above 65 or 70 years old. This is a combination of the EORTC trials that used radiation therapy. And when you divide patients between their age groups, what we can see is that there's very little representation of those patients that are above 70 years old or above 75 years old, as you can see in the top graph. However, overall survival doesn't seem to be different in patients that are elderly versus patients that are younger. which tells us that perhaps we can apply a lot of the data that has been generated to both the younger and the elderly population. However, we do know that some of the severe symptoms in these studies have been more common in patients that are older. The data from the EORTC is a little bit different if we look at the meta-analysis of radiation therapy. Here, what we can see that when we compare standard fractionation versus the altered fractionation schemes, we see that the elderly patients don't seem to benefit that much from altered fractionation. This, however, could be partially explained by an excess of non-cancer-related deaths in patients 71 years or older, and a lower compliance and tolerance threshold for these patients, particularly in those with poor general health status. So again, this gets us back to the concept of not the chronologic age, but the biologic age being more important. Indeed, comprehensive geriatric assessment can predict complications, radiotherapy tolerance, as well as hospitalizations. And multidisciplinary input is critical, but may not be sufficient for us to understand which patients are at highest risk for complications. So this is a study that classified patients whether they were fit or unfit to receive full-scale care by the multidisciplinary team. And out of the 7 patients that were classified as being vulnerable, when you apply a specific tool, such as the GCS8 tool, the geriatric age screening tool, we can see that out of those 7 that were classified as vulnerable by the multidisciplinary team, 6 were reclassified as fit and indeed were able to tolerate therapy. So again, we do need very specific tools and not just multidisciplinary assessment to try to understand which patients could be candidates for each of our therapeutic strategies. Well, we discussed about radiation therapy and standard versus hypofractionation radiation or altered fractionation radiation therapy. What about chemoradiation therapy? Again, perhaps some of the best evidence comes from the meta-analysis. This is the meta-analysis that's very famous that looked at the benefit of adding concurrent chemotherapy to radiation therapy, and that guides a lot of the therapeutic decisions that we have today. But we know from this meta-analysis that in those patients that are 71 years or older, the addition of chemotherapy to radiation therapy did not seem to benefit these patients in terms of overall survival. However, again, these patients are underrepresented in most of the clinical trials that have been included in this analysis. This may not be the full picture. Indeed, when we look at larger scale analysis, such as populational-based studies, this is a study looking at the NCDB, a very large population-based cohort in the US. When we look at those patients that are 71 years or older, and here we have about 4,000 patients that have been included in this analysis, there were several variables associated with the use of radiation therapy alone as opposed to chemoradiation therapy. So age, sex, race, distance from facility, comorbidity score, year of diagnosis, tumor site, and TNM. So people are making decisions on the basis of these tools. However, when we try to compare those patients that received radiation therapy alone, even though this is a commonly used strategy in our day-to-day practice, versus chemoradiation, we do see that the elderly patients indeed benefit from chemoradiation therapy. And this is true for the unadjusted analysis as well as with the propensity score matching analysis that you can see on the right. So perhaps by choosing to do radiation therapy alone in a lot of our elderly patients, especially without any specific tools used for assessment of whether they're fit or not to tolerate treatment, we may be leaving some benefits of therapy on the table. This is the multivariable analysis of the NCDB database showing that when you apply all of those variables in a multivariable model, concurrent chemoradiation therapy is associated with improved survival, and also age, comorbidity score, tumor site, and TNM. So you actually need to include all of these variables when you're having your day-to-day decision whether these patients to receive more intensified care or not. And this is a recursive partitioning analysis looking at how these patients may end up benefiting from concurrent chemoradiation therapy versus radiation therapy alone. And at the end of the day, specifically looking at elderly patients, the age does matter, whether they're 80 years, above 80 years old or less than 80 years old, but also the T stage, and importantly, as I highlighted here at the end of the notes, the comorbidity score. So again, it's not about chronologic age, it is about biologic age, here inferred by the comorbidity score, which is another specific tool that can be used, and we can use this to make decisions whether we want to use chemoradiation versus radiation therapy alone for these patients. So for our geriatric patients, a lot of other variables matter, and we need to take them into account. So not only comorbidities, but also performance status, functional status, polypharmacy, socioeconomic and psychological status, and geriatric syndromes. And at the end of the day, when you take all of this into account, if you consider your patients to be fit for therapy, they should receive the standard of care therapy. You should not be withholding intensified treatment for these patients. If they're frail, then perhaps they're candidates for de-intensified therapy or palliative care alone. But if they fall into the intermediate category, that's where a lot of these tools come into place, and then multidisciplinary decisions are key to try to understand the best therapeutic options for our patients. In terms of chemoradiation considerations, cisplatin can be very toxic for these patients. The alternatives are weekly versus bolus cisplatin, carboplatin, or the use of cetuximab, or the use of docetaxel. However, even in those studies that looked at cetuximab radiation therapy versus radiation therapy alone, the Bonner study, we can see that in elderly patients there doesn't seem to be a lot of benefit, but again, these are underrepresented in this clinical trial. When we look at weekly cisplatin versus bolus cisplatin, again, patients that are older than 65 are underrepresented in this clinical trial, but there seems to be a benefit there, at least in terms of overall survival, perhaps a little bit less so in recurrence-free survival. And when we look at docetaxel, which was a study done specifically for those patients that are unfit to receive cisplatin, we see that elderly patients comprise probably less than 20%, 15% of the population. So again, underrepresented, but here docetaxel seems to benefit both the elderly and the non-elderly population as well, and this could be one therapeutic option for our patients. If we look, for example, at some of the more recent studies, such as the nivolumab postoperative study, I should point out that these studies excluded patients that were above 75 years old. So again, we're going to have very little data on the benefits of immunotherapy for potentially curable resectable head and neck cancers. And obviously, these patients were excluded on the basis of the meta-analysis that didn't show that chemoradiation therapy could benefit these patients. But now we're left without any phase 3 evidence on whether we should be using immunotherapy for a big proportion of the patients that we see in our day-to-day practice. And I am not a radiation oncologist, I'm a medical oncologist, but I wanted to bring this study because it's one of the specific trials that have been looked at in elderly patients. It is a study that, as I understand, has not been presented yet and has not been published yet, but a version of the paper that has been sent for peer review is already available in one of the repositories online. This is the ELAN-RT study. This is a study that randomized elderly patients that were unfit to receive chemoradiation therapy to receive radiation therapy at standard fractionation or the split cord hypofractionation radiation therapy. And the primary endpoint was the rate of patients alive with complete local regional responses at 6 months. This was a non-inferiority trial, and indeed, the experimental arm was non-inferior to the standard fractionation arm. However, when we look at the grade 3 or 4 toxicities, we did see a reduction in the grade 3 or 4 toxicities. So even though this is a positive study from a non-inferiority standpoint, when we look at progression-free survival and overall survival, we can see that the split course radiation therapy did not do as well. And even the authors in this preliminary version of the paper caution against using this routinely unless patients really cannot tolerate standard fractionation, even though this is associated with less toxicities. So at the end of the day, when we think about our elderly patients, not only we need to think about the multidisciplinary care, which is depicted on the left, and it's true for any head and neck cancer patients, but we also need to think about the supportive care for older people with frailty, including transitions of care, ensuring fundamental aspects of care are met, communicating with the patient and their families, the caregivers, building up a picture of the person and their circumstances, decisions and advice about care, and also enabling self-help, a connection to wider support. So hopefully I've been able to convey to you that age should not equal exclusion to intensify therapy, but geriatric-informed treatment planning is essential. Age and comorbidity-focused clinical trials are desperately needed, and a comprehensive, patient-centered, goal-oriented care is essential if we want to give the full benefit of our therapies for our elderly patients. Thank you for your attention.
Thank you, William. I'd like to invite now Dr. Luis Kowalski. He's a head and neck surgeon from University of São Paulo and AC Camargo Cancer Center in Brazil. He's going to talk about considerations in the surgical management of these elderly patients. Dr. Kowalski.
Thank you, Thiago. Good afternoon. So I have these disclosures, and this is the outline of the presentation. Of course, it's very important to consider in surgical planning the assessment of, in old patients, the assessment of frailty and comorbidities. These facts can modify our planning, and I will try to show why and when. There is a lot of evidence-based surgical approach and treatment modifications that we can plan in older patients, and also we'll talk about perioperative considerations and outcomes data comparing elderly and young patients. We define frailty as the progressive loss of strength, endurance, and psychological response to stressed situations. And the prevalence is very high. You can see that in the general population, about 10.7% of the patients are considered frail. In head and neck cancer, the rates of frailty can reach 32%, which is much more than is observed in other cancer patients. That is in this report, the rate of frailty is seen in 21% of the patients. How we access? There are several tools. The most used are these G8 geriatric screening that is used initially for all patients. And for the patients that we identify frailty, we will apply the comprehensive geriatric assessment tool. Also, it's very important to assess comorbidities in elderly patients, and we have seen, you can see here the various tools that we have in the literature. The most used is the adult comorbidity estimation 27, the ACE27. It's easy to see in several publications in the literature that comorbidities are more frequent in elderly patients, and elderly patients with comorbidities have experienced a reduction rates in survival, as several publications have shown. The problem is that we change the treatment because patients are old. You can see here that patients that are younger than 69, 89% of them usually go for standard treatments. And the rates of standard treatment drops to 36% when the patients are 8 years or older. Most of the time, these modifications in the treatment are because of frailty or comorbidities. But not only those factors affect the decision. There are some physician factors. Some physicians do not believe that older patients could be treated equally to younger patients, and just because they are old, they decline to offer the standard treatment. Some patients, because they consider they are old, they do not accept the standard treatment, they would prefer some less aggressive treatments. And it's hard sometimes to convince them that they should undergo the standard treatment. So the presence of comorbidities is really a remarkable factor that affects the decision of patients and physicians. And other factor that is very important for all the patients, because they have difficulties in travel from their homes to the hospital, is the distance from the hospital to their homes. So it sometimes affects the decision. They would like to receive some treatment that is quicker than long treatments. In this publication, we have seen that patients that are older, when they have comorbidities, they are really the main reason for the change in the treatment. And when we have changed the option of treatment from standard to substandard treatment, there is a tremendous loss in the survival expectation. And in multivariate survival analysis, you can see that the modification of the treatment is #1 variable associated to decreased survival rates. Also, we have shown in older patients that the presence of comorbidities associated with a stage of disease, site of tumor, etc., is associated with the risk of recurrences. You can see that when the patients have all the favorable factors, about 10% of them will have complications. But when they have all the adverse factors, 100% of them will have complications after surgical treatment. We can see that in other publications that the presence of comorbidities and the length of the operation, the time the patient remain in surgical OR are the main factors associated to the risk of complications. But when we analyze survival rates, age is not a significant factor. Comorbidities are much more important, as you can see here in several publications. In our analysis of old patients submitted to surgical treatment, we could also show that the presence of comorbidities and the severity of comorbidities were the main factors associated to reduce survival in this population. So, considering all those factors, it's really very important, especially for this population, to have a plan for rehabilitation before surgery, aiming to reduce the risk of complications. And what can we do surgically for reduce the risk of complications for older patients? Well, whenever possible in oral cavity tumors, we should perform intraoral resections, avoiding larger access to the oral cavity. Considering the mandibular management, whenever possible, we should perform a marginal mandibulectomy. But several times, because of advanced stage, we need to perform segmental resections. For the management of the neck, we should continue to perform elective neck dissections or sentinel lymph node biopsies for old patients. We shouldn't avoid the use of a neck approach aiming to reduce the risk of the operation. We should do our approach to the neck as we do for young patients. Of course, we should do the good neck dissection with more than 18 lymph nodes in the specimen. And the only thing that we could modify is reduce the indication of bilateral neck dissections and preferring in some patients the use of operation in 2 stages or to use irradiation for the contralateral side of the neck. And for reconstruction, local flaps are usually the best way to manage those patients. Sometimes to avoid microvascular, we will use myocutaneous flap. Very frequently, we use the pectoralis major flap. But our experience shows that even older patients can undergo reconstruction with free flaps using lateral tie or the forearm flaps. So when we analyze the results in the long term, we see that quality of life of patients who undergo radical treatment, even if they are old, they have similar results that can be achieved with younger patients. We need to develop really evidence-based treatment algorithm to treat older patients, and that includes the analysis of frailty and comorbidities as key factors in the decision, but all other tumor factors should be treated like we treat younger patients. And in the design of those algorithms, we had considered that patients who fit for treatment should receive the standard treatment. Those patients who are pre-frail, they should receive rehabilitation and the treatment of enhanced supportive care, and then they should receive the standard treatment. Only the very frail patients that cannot be recovered from this status, they should receive the intensified treatment or just palliative care. And those patients that can be rehabilitated by pre-rehabilitation, they should receive the standard care. In our team, of course, we need to include the geriatrician to help in our decisions. And this team has a lot of responsibilities. Some responsibilities are, of course, related to preoperative optimization, risk stratification, treatment planning, and survivorship care. We really need to have protocols, good surgical planning, and the most important message that I would like to leave to you is that under-treatment is more harmful than age-appropriate treatment. And the take-home messages are that chronological age alone should not determine the treatment eligibility. Comorbidity burden and functional status are better predictors than age. Comprehensive geriatric assessment guides the treatment individualization. Standard surgical principles should be appropriately to selected patients, even if they are elderly. Multidisciplinary care optimizes outcomes across all age groups. And finally, rehabilitation can improve surgical tolerance in vulnerable patients. Thank you very much for your attention.
Thank you, Dr. Kowalski. So we have a couple of minutes to 1 or 2 questions. Is there any question from the audience? I don't think so. So I'm just gonna ask all the speakers, how feasible is it to us to have a comprehensive geriatric assessment to all our older patients? We know that in head and neck cancer, the majority of our patients are gonna be at least 65 years or older. In your institutions, do you apply this? William, Fernando, I don't know if we have a mic here.
Yeah, I'm just gonna go here. Also, maybe I'll start. Indeed, I mean, especially in resource-constrained contexts, I think it could be very hard for you to have comprehensive geriatric assessment for every single patient. But at the end of the day, it's not a very expensive tool. It's just a matter of organizing the services better. I have to say that we are in the process of implementing that at our own institution as we build or reshape our program. And perhaps one way to do this is to have certain comorbidities or age cutoffs for you to send patients for comprehensive geriatric assessment if it's not feasible to do it for everyone. I think what is very interesting, even though it was a small-scale study, but the study that I presented I think is very interesting, that showed that just tumor boards alone and multidisciplinary evaluation that does not include a specific tool or specific assessment for geriatric evaluation is not enough. So you indeed need a more formal evaluation of these patients if you want to figure out whether your patients are frail or not.
We have one question from the audience, please. Microphone 2.
Yeah, I've got a question. Listening to the session, and I'm sure we could all move to a position where we feel there's no chronological age that should determine treatment. We could all talk ourselves into that there's no one age, because one 70-year-old is like another 80-year-old, another 50-year-old. We shouldn't use chronological age. But one of our strongest bits of evidence is not to give chemoradiotherapy to those over 70. And that's been borne out by quite strong evidence. Do you think we should stick with that, or we should further challenge that and make it about frailty comorbidity? Do we challenge the 70 even when there's good evidence, or do you think we shouldn't ever have a number?
Well, I don't think we should have a chronologic age number at all. I think that, even the evidence that has been generated is based on very limited patient numbers. And I think once you start going into the more populational-based analysis, which is obviously less controlled than a specific clinical trial, we do see that it's not really about an age cutoff, but it's more about the comorbidities, the stage, and other factors that come into play. So I don't think we should hold ourselves to one specific chronologic age.
Yes, the same. But we need to think about the consequences of that treatment because of fibrosis, and this patient has more aspiration, this patient has more complications, and pneumonia, and I think that we need to consider, in some instances, surgery is better than chemoradiation. In my practice, I discuss in a tumor board. I think it's not a question of how difficult it is to apply or how it costs, but it's a problem of time, because you need to have time to apply these tools. But in general, I worry about chemoradiation. In general, I prefer to indicate surgery in many cases.
Well, of course, chronological age is not a factor right now. We are operating patients at 90 years. We have a patient with 100 years that was operated. It depends on the physical status of the patient. Patients are healthy today than they were in the past. I think that 30, 40 years ago, it was hard to offer a patient at 80, 85 years a surgical operation. But now they are healthy, and we have good monitorization, we have good support for postoperative period. Of course, there are risks, but if we do the necessary care preoperatively, during the operation, after the operation, the patients can be safely operated.
Thank you. So in the interest of time, we're going to move to the next table. I'd like to thank Aline and William and ask Dr. Kowalski and Dr. Fernando to stay in the stage to moderate the next table. And also I'd like to invite Dr. Claudio Cernea and Dr. Fernando Dias to join Dr. Kowalski and Dr. Fernando Valder in the moderation of the next table.
Good morning. Good afternoon, actually. So, thank you very much for the invitation to moderate this, and my co-moderators are over there. More moderators than speakers, that's a first. So, I'd like to invite the first speaker, Professor Rogério de Divitis, who is going to talk the subject of this second part of the panel of the Brazilian Head and Neck Society is on advances in oral cavity cancer. So Rogério de Divitis is a professor of surgery at the University of São Paulo School of Medicine and a full professor at the University in Santos. And he's going to, and the vice president of the Brazilian Head and Neck Society. He's going to speak about feasibility of molecular margins. Rogério?
Good afternoon. Thanks, Claudio. Nice to be here. So I'll talk about molecular margins analysis in oral cancer. So why margin status matters in oral cancer? In fact, it matters a lot since you have a lot of tables and symposium during this Congress. So local control and survival depends heavily on the initial negative margins in order to obtain the as best as possible prognosis outcome. Recurrence rate varies a lot, from 20% in case of clear margins to 90% of recurrence in case of positive margins. So negative margins indicate complete resection and a trend to have better oncological outcome. And of course, it's margins are prognostic factors, important prognostic factors that are under direct control of the surgeon during the surgical approach. Mainly in countries with limited resources, there is some limitation of using other tools besides the conventional histopathology. So, in general, frozen section, intraoperative frozen section is performed, but there are some difficulties in obtaining the adequate sampling, and the interpretations also varies a lot. And regarding the formalin fixation, there is some shrinkage after the manipulation of the material, and sometimes it's also difficult to differentiate between what is closed margins or really clear margins in those specimens. So regarding shrinkage and artifacts, we have till 59% of shrinkages, mainly for floor of the mouth, and it can alter the final report of the true margins. Another point is the way we can obtain we can sample in the tumor or the margins. Nowadays, in general, the specimen-driven is preferred instead of the tumor bed margins sampling, since it provides better local control and a more comprehensive assessment of the entire border of the specimen. When the frozen section examination shows that there is positive margins, when we perform the re-resection, it does not allows us to have the same outcome as if initially negative margins were obtained. So the ideal scenario is when in the first resection we can obtain free margins. So nowadays, mainly in countries with limited resource, we have as intraoperative approach the cross-examination by the surgeon and the flow section in order to guide the extension of the resection. And in the post-op, in order to stratify the indication for adjuvant treatment, basically the histopathologic analysis, but molecular analysis has increased in the last decades. So the rationale for this presentation is that even when we obtain R0 resection, there are rates from 12 to 30% of recurrence. So microscopically, normal mucosa surrounding the tumor may still host molecular abnormalities that cannot be observed under the conventional examination. And in such cases of negative margins, possibly some molecular findings could explain the reason for these high rates of recurrence, even under free margins under the conventional analysis. So the concept of molecular margins is the analysis of genetic, epigenetic, or proteomic markers in the scenario of negative tumors or negative margins under the histopathological evaluation. And thus, the purpose is to identify residual disease or in the scenario of field cancerization. It's a review that was published some weeks ago. You can realize that there is a lot of different approaches for molecular analysis. The first one that has been described in the most published item is, of course, P53. So I will highlight some of them in the next minutes. So TP53 mutation has been widely studied. It's tumor suppressor gene with mutations that can be observed in initially clear margins, and when it's observed, there is some increase in local regional recurrence rates. However, there are some limitations that means that only from 40 or 60% of the tumors harbor PT53 mutations, and there is a myriad of potential mutations. So it's another aspect is that it's difficult to sample all the margins in order to verify the real status of P53. Eukaryotic translocation initiation factor 4E increases 7-fold the risk of local regional recurrence. It jumps from 6.9 to 56% when we go from a scenario of absence of this marker to the presence. There are other proteins, biomarkers I'd like to emphasize, cyclin D1. It's is related to checkpoint regulation. It's an oncogene. And when it's positive in the margins, it represents a worse rate for a local recurrence with a hazard rate of more than 5.5. Microsatellite instability is also another evaluation previously studied. It's secondary to defects in DNA. And it's possible to identify cells with malignant potential in this scenario. So it also is responsible for some increase in local recurrence rates with a rate of 7.2. Loss of heterozygosity has been also studied, and for some genes, it's when present also represents some increase in recurrence rates. Copy numbers alteration, it's a gain or loss of segmental of entire chromosomes. It has also been evaluated, and it's also responsible for some higher rate of local recurrence. epigenetic markers for some genes has also been related to survival rates and recurrence rates. And finally, the near-infrared fluorescence imaging. It has the advantage of giving us the feedback during the surgery in the intraop period in order to achieve adequate margins. It has been presented in other specific tables along this conference. But it provides us a real-time assessment in order to establish the adequate margins for the patients. So it's a topic that changes a lot and very fast. There are a lot of future perspectives, as we can note here. And even for countries like Brazil and other countries with some limited resources, we can try to use imagination, since AI is widely available, in order to apply techniques that can be used even with some lack of resources. And finishing, as take-home messages, molecular margins analysis is an important complementary approach for histologic evaluation in relation to the conventional approach. For some markers, there is a strong evidence base, and things change a lot. And we have to consider these tools as important tools for improving the obtention of free margins and diminishing the recurrence rates of our patients. Thank you very much.
Congratulations, Rogério. Excellent talk. You are on my seat, by the way. And I'd like to invite Fatima. Professor Fatima Matos is professor of surgery, PhD in our university. I had the privilege to be on her board. And most importantly, she is the president. She's my boss. She's the president of the Brazilian Head and Neck Society, the present president. So she's going to talk about the incorporation of new histopathological factors in oral cavity staging. Fatima?
Thank you, Claudio. And until September, and then September finish, finally. So I'm very happy to be here in Liverpool, my first time here, and incredible city with incredible people. And also I'm with this incredible team, the dream team here in the stage. So today I'm going to talk a little about, this is my disclosures, but I don't, in this presentation, they don't have any problem. And my agenda today, I will talk a little about the problems that we have with TNM system. And also I will talk a little about some promising histopathological markers that they are in study nowadays. And then I will talk about the incorporation of them in our practice. So TNM system has many criticism about it because it doesn't make evaluation of biological behavior of the tumor, especially in early disease with aggressive behavior. And also in immunotherapy area, we have another problem that the microenvironment of the tumor isn't evaluated. So I'm going to talk about 3 histopathological markers that we have many studies and can be very useful in the future as the same that happened, and I hope that the same that happened with depth of invasion that was incorporated in the 8th edition of TNM. I think that probably they will take part of the next generation of TNM. So tumor budding is defined as the presence of isolated single cells or small clusters than 5 tumor cells at the invasive front of the tumor. And the prognostic value that can be seen in literature is the increase of lymph node metastasis, poor overall survival, and also reduced specific survival. Worst pattern of invasion was first related in literature in 1973 in larynx cancer by Jacobson. And this is a very promising marker that in Brazil, in some centers, we are using it in pathological reporters. And it increases also, the prognostic value is related to increase in lymph node metastasis. And it also is associated with poor overall survival and also reduced disease-specific survival. In this diagram, we can see for surgeons that can't understand the histology of the tumors, we can see how works the tumor budding and also the worst pattern of invasion. The worst pattern of invasion has 5 grades, and I will show you there are some studies that are proposing to put 3 grades because it's similar in the results. So another important prognostic marker is the tumor stroma radio. The tumor stroma radio is one that is associated with microenvironment of the tumor. And it's very interesting because it's very cost effective like the others, and also it's associated with poor outcome in the patients that has high grades. So we are going to see some papers in literature that embase all my affirmations. This is a review study published last year, and it evaluated many of these histopathological markers, parameters, and they concluded that these histopathological markers will be very useful and can indeed preview the worse overall survival, disease-specific survival, and disease-free survival. This another study is a meta-analysis published in 2022, and the authors evaluate the worst pattern of invasion, tumor budding, and the tumor radio. And they concluded that worst pattern of invasion is related to worse overall survival, and also tumor budding, disease-specific survival, and tumor stroma radio to disease-specific survival, worse disease-specific survival. This another study evaluates histologic grade with worst pattern of invasion and tumor budding in early tumor cancer of oral tongue. And they concluded that worst pattern of invasion and tumor budding is better than tumor grading to evaluate the prognosis. Here we can see in the upper part of the slide, we can see the curves of overall survival of tumor budding and also of the pattern of invasion, and we can see that tumor budding, high-grade tumor budding, and worst pattern of invasion 5 has a worse performance in the overall survival. In this paper published this year, where Dr. Luis Paulo Kowalski take part, they proposed a modification of the worst pattern of invasion. And the worst pattern of invasion will have in this proposal 3 grades, 1, 2, and 3. And also tumor burden score will have 2 grades too. 0, 1, and 2, 3 grades, sorry. And here we can see the curves where the survival curves where the high-risk group has a worse prognostic in the evaluation. So how we can integrate prognostic models into our clinical practice? And how this can impact the conduction of these patients. They can enhance the prognostic accuracy. This incorporation can modify our practice, and especially in early tumors with aggressive behavior. And also we can, like what happened with DOI, we can also upstage tumors based on the grades that we can find in these histopathological markers. And we have many challenges to integrate these prognostic markers to our practice. And how can we moving forward? How can we move forward and do this? In fact, in the real world, we need to accumulate evidence from meta-analysis. We can construct consensus with these histopathological markers. And also, we can incorporate into our pathological analysis with our pathologists to evaluate these markers and change our practice. So my take-home messages, these 3 markers that I have told you, worst pattern of invasion, tumor budding, and tumor stroma radial, they are validated, and especially for development countries, it's cost-effective also. And they are significant, independent prognostic factors. They can enhance the prognostic accuracy, and also then they can provide personalized management of this patient, especially those with early stage tumors with aggressive behavior. Thank you so much.
She, as a president, she can sit on my chair. I won't complain. So. Just one quick comment. Is Sedana here, the pathologist? No? Okay. So as a surgeon, and I take care of patients like most of you, I think that the worst pattern of invasion, the pathologists, they put that on the report. And when my patients read that, they almost have a heart attack. So, and I keep explaining to them for 10 minutes, what is that? So I think it's precise, but not fair, in my opinion, to be in the report. Anyway, the last speaker of this table, if I can open here, oops, is Leandro, not the least. By the way, we have only presidents, past presidents and the present president here, and a rising star, Professor Leandro Matos. He is going to speak. He is one of the experts about lymph node sentinel lymph node biopsy in our environment in Brazil and in our institution as well. And he is a rising star, and I guess probably a future president of the Brazilian Head and Neck Society. Leandro.
Your speech, not mine. Hello, everybody. Thank you for the podium. I'm here. We all could see a lot of lectures about sentinel lymph node biopsy in oral cavity. I will not talk about the same that everybody did in this brilliant congress. I will try to do a parallel between what we do in clinical practice in Brazil and with what we have in literature. Those are my conflicts to disclose, nothing related to this presentation. And I will quickly pass through the Brazilian reality of oral cancer, that is the similar reality of other low-income countries. I know Brazil is not a low-income country by definition, but we have a lot of people in vulnerability in our country. And again, do this parallel between Brazil and the literature regarding sentinel lymph node biopsy in early stage oral cavity cancer. Those are our curves. These are the curves of our institution, the University of São Paulo. University of São Paulo, our oncological center, treats around a quarter of patients from the state of São Paulo. I state with around 40 million people. So we have here a good representative of the disease as in São Paulo state and also from Brazil. And as you can see poor curves, especially patients with advanced disease, but I like to advise that even patients with early stage disease, they have not very good results in our country. And here you can see, of course, that patients with lymph node metastasis have a worse prognosis. We already know that this is one of critical prognostic factors in our patients. And firstly, we tried to study what is the rate of occult metastasis in early stage disease from 7th edition AJCC, and we reached like 25%, that is similar to literature. And then we started to perform a sentinel lymph node biopsy in our institution around 2012. It was not a research protocol from the beginning. We started doing it as clinical practice, using the results from Europe principally. And here we performed more than 170 cases, and we have about 12 to 15 cases per year only in our institution. We use SPECT-CT with gamma probe, and we also, since 2017, incorporated indocyanine grain in our routine. I will present specifically the results of 120 cases from the initial group of patients. And here, firstly, was a very great concern about our team if we are doing right to not perform the elective neck dissection. People use it to have in mind that very bad results that we have one time in life, and we used to say, I will not do this anymore, right? But we proved in our historical cohort that sentinel lymph node biopsy in the beginning of our series were similar to elective neck dissection. And again, with more experience, we could achieve very good results in terms of oncological results. What is quite similar to literature. If we look for the 5 meta-analyses that we have and also the 2 randomized controlled trials, we do not see any differences in overall survival comparing sentinel lymph node biopsy and also elective neck dissection or selective neck dissection. The same we could see for disease-free survival, and more specifically, maybe the best outcome for evaluating sentinel lymph node biopsy, the regional failure, is also quite the same between those 2 approaches of the neck. So we are very confident that we can use sentinel lymph node biopsies as a safety method for our early stage patients. We had in these 120 initial patients 7 cases of false negative cases, what represents around 6% of our group of patients. That is absolutely quite similar to literature. And what I'd like to see in this slide is once we do more studies, the sensitivity goes down. This is absolutely normal because the patients are followed for a more period of time, and then the recurrences occur, what is natural. So we are talking about 80 to 90% of sensitivity, what means rates of 5 to 10% of false negative cases. That is quite similar to literature, our series also. We also put together all cases performed in Brazil until 2020 in this publication of a real-world data. These patients were not enrolled in any clinical trials. They are operated on clinical practice as we usually do, as we usually indicate for our patients. And here we have the results of 407 patients from several different institutions from Brazil. And what we consider to be very conservative in this analysis, a false negative case was any case with regional relapse independently or regardless time from this recurrence. And what we could observe is an accuracy in around 90% in detection of these recurrences during follow-up. And we could not see any difference between these recurrence rates and the stage, specifically PT3 stage in the new AGCC staging system. And what we have in Brazil is a curve, accuracy curve very similar to other curves from the literature with a rate of around 6% of false negative cases. We also had very good oncological results, similar to patients treated with elective neck dissection for early stage cases. Here we evaluated the quality of life of these patients, and statistically, for sure, the quality of life in Washington, evaluated by Washington score. Thank you. It was greater from patients with sentinel lymph node biopsy, but it's not that's very impressive result. But here in the bottom on your left, you can see that known patients submitted to elective neck dissection reported excellent or very good quality of life in the last 15 days, for example. Known patients reported that, besides a very good result for the elective neck dissection itself. But we could also have very good results in terms of quality of life in different domains of this score, and also specifically for appearance. We don't have a very big scar at the neck. Chewing, probably because in sentinel lymph node biopsies we usually include patients with small tumors, but the final score was higher for sentinel lymph node biopsy. Those are the results of QALY evaluation, and here you can see a very good high QALY in a very short outcome, 9 months. And I really like this slide because in 9 months we have 80% of patients submitted to sentinel lymph node biopsy without any symptom related to the procedure or any symptom at all, comparing to just 50% of patients that are submitted to elective neck dissection. Those results are similar to other functionality evaluation at different randomized controlled trials and also meta-analysis, as here the paper published in JCO in 2020. I also advise everyone to take this recommendation in mind. Here we can have a very good amount of literature to perform lymph node dissection in our practice. So to conclude, firstly, sentinel lymph node biopsy is feasible and with a quick learning curve, of course requiring training, attention to case selections. At least lymphoscintigraphy is important. If you have a SPECT CT is good also. We have to demystify the method for our clinical practice, but is accurate, safe, and oncological results are similar to the conventional approach of the neck. Once we are here in the island of the poet, the most famous poet in the humanity, why not to use his own phrase to summarize this lecture? Less is more. I don't know if this phrase is from him or no, probably not, but I think it fits very well in this occasion, okay? And just to conclude, Brazil can be seen as a model in this implementation of sentinel lymph node biopsy in the last decade. We have few cases, unfortunately, of early stage disease in Brazil, but this technique applies very well for these patients. It is oncological safe. We have surgical results demonstrating a good assistance to our patients with high quality of life scores. And thank you very much for your attention.
Thank you very much, Leandro. And I think we have a couple of minutes before the presentation for the next Congress. So if there is any question, please go to the microphone number 2. The other one is here, so I hope. No, it's there. Podia pegar o microfone lá.
A question.
Remco, okay.
For the first speaker, the markers in the surgical margins. You mentioned markers, molecular markers, but how are related also, you are at the surgical margin, but were they in the center of the tumor? Because is it something which is from the whole tumor or only from the margins? You know what I mean?
Thanks for the question. For some markers are not always present in the tumor itself, so it's a limitation for the final study. You have to consider, for example, for P53 around 60%, so sometimes it's not present in the tumor. So you have to consider the status in the tumor and also in the margins.
Yeah. And can you determine it in the tumor, or you always have to do it in the margins, the markers you showed?
Yeah, in the margins.
But yeah, is it also possible to do it in the tumors, and you can take a biopsy, of course, and then
yeah, no, of course, yeah.
And otherwise, you have to have the surgical specimen, and then you know.
Yes, of course. But in order to verify the prognosis, the question is for free margins under the conventional analysis when you have the presence of the marker.
Any more questions from the audience? Fernando, you have a comment to make?
Oh, yes, thank you, Claudio. My question is for Professor Rogério de Vitis. Indeed, the question of margins is a real-world issue. And there are several interesting things about this now. We know that in the upper digestive tract, there are differences between the recommended margins when you compare the tongue, other areas of the upper digestive tract, and nowadays, because of the robotic, the deep margins for instance, the radical tonsillectomy. But what really bothers me or concerns me is, first, when you need to re-resect a compromised margin, positive margins. My feeling is that we avoid being radical in this re-resection. And I think that there is a controversy in terms of the results. Some papers, they say that when you need to re-resect a tumor, your results are worse than when you get the resection the first time. In this question, when you face a margin which is free of cancer, but is compromised by dysplasia, severe dysplasia, what do you recommend to do? How many millimeters do you re-resect this margin?
So first, when you have free margins in the very first approach, the final outcome is better in comparison of re-resection during the first operation time. It depends on regarding your question, depends on the distance. For, less than 1 millimeter is considered positive. The ideal margins is more than 5 and possibly more than 7 millimeters. But when you have such a result after the approach, when the operation has already been performed, you have to consider it's just a dysplasia. For oral cancer, I prefer, if it's severe dysplasia, to perform a second look.
Well, if there are no further questions, I'd like to invite Professor Fernando Diaz to the podium for the message concerning the next coming.
Oh, Claudia.
It's you.
I'm in charge for once, for the last time. Thank you very much.
Sorry, okay.
I would like to thank the Brazil team for this tour de force from both of these sessions. Thank you very much. So, just a second. So what we've done in IAOO, the last couple of congresses, we've invited the nationality, the team that are going to run the next congress to have the entire floor for an hour, hour and a half. This opportunity was afforded to me and my colleagues in Korea. We've afforded this opportunity, and I think you'll do the same for our Hong Kong colleagues at the end of your meeting in 27. It's a nice tradition. So I'm going to ask, apart from Luis and Fernando, for the Brazilian team to leave the stage, and we'll do a quick swap, and we'll do the Brazilian presentation in a moment. Okay. Thank you. So I'm going to ask the executive officers of IAOO Council that are remaining. I'm going to ask Brazil team who are already up, come and have a seat. The Hong Kong team, I think Richard and Jason, to come and have a seat. Representing our local organising committee, Professor Andrew Shaki. Representing Liverpool Head and Neck Centre, Terry Jones, please come and have a seat on the stage. I won't keep you very long. So thank you for staying to the end. We won't keep you long. So could I get the slides for the closing ceremony, please? Okay. So we've reached the end. I am at once very sad and very happy. So thank you for everybody for coming. I'm not going to do extended thank yous. I think the main two that I wanted to do, just to reiterate, obviously my colleagues in the local organising committee and the scientific committee, to thank them, and our PCO WorldSpan and Kirsten and all her staff. So a very quick round of applause. There won't be too many, but thank you. Thanks to the sponsors, Regeneron, Johnson & Johnson, for their generous sponsorship. I hope you've spoken to them while you're here. Some numbers. Okay. So the numbers are here because they've improved since I last stood here. What we found, although 1197 attendees included some virtual, the number of in-person attendees, I promised Dr. Shah 1,000, we got 966. So we fell short, I'm sorry. The pre-Congress was 455. The number of countries involved in the end was 55. We sold 360 party tickets last night. And on stage, the members of the Beatles totaled 8. That's what you call an in-joke. So a very successful meeting, and I'm thanks to the whole team. And congratulations to some of our abstract winners, I think. Is that right? So I'm inviting Andrew up to make that presentation. And a last round of applause to our scientific chair, Andrew Shaki, please.
Thank you, Richard. We had some fantastic oral papers presented, and equally posters, and the organising committee really wanted to recognise those that were seen to rise above the crop and be really quite fantastic. I know that some of the awarded oral prize presenters won't be in the room this morning, but I think Claire Patterson has already left. But if you are here, Claire, please make your way down. Otherwise, I'd ask the other 4 people, Randa Ghazal Aswad, Remy van der Vood, Elizabeth Crosby-Jones, and Yichun Lee to come forward, please. Don't rush.
Well, congratulations to them.
Oh, I know you're there, Randa.
We've got Randa.
And it looks like Remco is going to come and accept on behalf of Remy.
Congratulations. Okay, well done. I can take it home for Remy if you... For Remy, if it's okay.
Thanks, Remco. Congratulations to them, and then equally to our selected poster prize winners, if they're here, Rosa Maria Lopez Pintor, Hugo Fontaine-Cola, and Gui King Lao. My apologies for pronunciation of any of those names.
Thank you for staying. So it's Liang on this one? Good. Accepted on behalf of a colleague. There we go. Okay.
Well done.
Well done. Thank you very much.
And I'm delighted to say that that is the conclusion of the scientific program.
I bet you are. So can we switch to the presentation for the Rio team, please? And I'm not sure whether it's both of you or Fernando or Luis who...
Both of us.
Okay, can you both come up and... So we like to do this. This is a fun part because we can look forward to what happens in 2 years' time. So there we go.
Thank you.
Congratulations. Okay.
Thank you. Thank you very much, Richard, and congratulations for you and your team for this wonderful meeting. Very pleasant meeting, actually. It was a pleasure for us to meet your city. We knew already by the, watching Liverpool and Everton playing in Brazil by the TV. So I will start with a quick video that is self-explained video, and we will finish with some very quick information regarding the venue.
So, as you saw, Rio de Janeiro has an international airport and a domestic airport, direct flight from almost everywhere in the world, very easy to get there. And the convention center is located in the same street of the 3 hotels that belongs to the same company, which offer 3 different categories of rooms, which is very convenient. All of them by walking distance. It's in front of the beach. It's a beautiful place, beautiful scenario, as you can see here. And the convention center has proven to be a very adequate place for national, international medical conventions. And these are the three hotels, 3 categories, nearby, walking distance, for those who are willing for more economic place to stay. Also, walking distance, you have 2 additional choices, very easy to walk from there to the convention center. And also, we, in addition to the restaurants inside each one of the hotels, there are 3 additional restaurants with 3 types of different foods, and the kiosks at the main area of the beach that are at the disposal with walking distance. We have already assembled an executive committee, particularly emphasizing the role of our colleagues from the dental area and the rehabilitation. We are in the next step to create some international advisory boards. We are doing this in the next weeks. And finally, we have already a very strong group of sponsors, including the Brazilian National Cancer Institute, the Brazilian Ministry of Health, dental schools from Rio de Janeiro, University Federal and State Federal, and the societies of craniomaxillofacial surgery, Society of Periodontology, and Society of Stomatology that already gave us their support. Luis, please. Richard, would you like to come?
Thank you, Fernando. If you have my slides. Yeah, thank you. So, we would like to thank the members of the board of IAOO for allowing us to have this 11th Congress in Rio. In fact, we have already had one IAOO meeting in Brazil. It was in São Paulo, 2015. It was the 50th Congress. It was a tremendous success. We have a lot of support from sponsored societies from Brazil, societies for all over the world, and several top institutions in the world also participated using having time for round tables with debates, etc. It was the first time in São Paulo that we had more than 800 people. About 50% were people from Latin America, but 50% were people from other parts of the world. So it's really not difficult to go to Brazil, São Paulo, Rio. We have direct flights to there. And in São Paulo meeting, we had at that time more than 650 papers that were presented as oral presentations or posters. For this Congress, our president, Ian Ganley, the president of the Congress will be Fernando, and myself and Sniho Patel will co-chair the scientific committee. We designed this theme for the Congress, charting the future of oral oncology, precision medicine, and AI-driven innovations for global cancer control. We'll have really, it's a unique opportunity because it is the second time we'll have this Congress in Latin America. It marks really an area of the introduction of AI in our clinical practice, and we are sure that in Rio we will have a clear definition of this area, and we will be addressing in this Congress global health equity, AI integration, and personalized cancer care. We will have a lot of opportunities to exchange our experiences throughout all the program, and we will have, of course, keynote lectures, grand debates, society department symposium, We will try to have even more than we have here. That was amazing to have the number of international societies participating. We will, of course, have round tables and oral and poster presentations. And we will focus the areas of AI and digital health and precision medicine. Of course, we will have also some other topics that are burning questions that we have in our field. We will talk a lot about robotic surgery, AI in medical decision making, and we will talk about, because it's a terrible problem for us, especially in South America, the late stage of diagnosis. We need to discuss very thoroughly topics on cancer prevention and the strategies for early diagnosis. We will have also in the Congress lunch with the professors and several workshops in research methods, clinical innovations, and multidisciplinary care, and also live demonstrations of AI-assisted surgical planning. So we invite you to be part of this transformation where precision medicine and AI-driven innovations converge to ensure no oral cancer patient is beyond the reach of excellent cancer care. So we welcome you to Rio in 2027. Thank you.
I've been the guest of Luis at conferences in Brazil before. Don't miss it. It'll be very good. We've actually awarded the Congress for 2 years. Following that, we kind of rotate through from Europe to the Americas to Asia Pacific. And the Asia Pacific nomination that was successful in the end was to Hong Kong in 2029. So to represent the Hong Kong Congress, which is 4 years away, Jason Chan. Okay, Jason.
Thank you, Richard, and thank you, Andrew. It was a wonderful Congress this time. I think we have a lot to live up to in 4 years' time, but luckily we have 4 years to prepare for it still. So the 12th World Congress of IAOO will be in Hong Kong, and just to start off, a little bit of a video to give you a flavor of what Hong Kong's like.
Ladies and gentlemen, welcome to Hong Kong International Airport. Local time is 8 a.m. and the temperature is a balmy 25 degrees.
Good morning. Today is sunny with a temperature of 29 degrees Celsius.
Hong Kong. This is the place to be. wonders are around every corner and adventures can happen anywhere. Place that meets the world.
Okay, so that's just a little bit of a background about Hong Kong. And the 2029 will be organized between the Hong Kong Society of Otolaryngology, Head and Neck Surgery, and the Hong Kong Association of Oral Maxillofacial Surgeons. Roughly, it's in probably we're thinking about November 2029, but that's still in the works. And it'll be held at the Hong Kong Convention Exhibition Center, which you see here on the top right corner, right in the center of Hong Kong, right at the harbor front. With an expected attendance of 1,000 to 1,500, this conference center has more than capability of hosting that number of people. With the theme of East meets West, preliminarily, Richard and I are co-hosting this conference. With support from Joseph and Zenon, who are also from the local staff, Eric Lau, who's also in the audience there as well. We also have support from the authority locally in Hong Kong, including our local public healthcare system, the Hospital Authority, both universities which have the 2 medical schools. The Hong Kong Tourism Board has already pledged their support for this, as well as the societies I mentioned earlier. So just a little bit of Hong Kong, and I'm getting between lunch now. It's a strategic location. You're basically about over 1 billion population is within 5 hours flight of Hong Kong. It's a gateway to mainland China with superb infrastructure, be it trains, planes, and automobiles. There's a lot to do in Hong Kong if you want to go out for hiking. It's a good time in that time of the year in November. You can go shopping, you can go sightseeing. And logistically, it's extremely easy to travel to with what you see here, over 1,000 flights in and out of Hong Kong, and over 200 destinations around the region as well. And about Hong Kong, again, with the US dollar coming down, it's actually getting cheaper to go to Hong Kong now, with the pound going up and the euro going up. There's no sales tax or VAT, unlike here where there's 20% VAT. Language is predominantly in English, really minimal visa requirements for traveling there, and the local transportation is extremely easy. And in the climate in November is pretty cool and dry. It's not hot and humid like it usually is in the summertime. So we'd like to welcome you all to Hong Kong in 2029. Thank you.
So I'm pretty much done. So before I hand over to your new president, Ian Ganley, if you come up, Ian, really, they're just my last words, really. Something I don't get to say very much as a head and neck surgeon in Liverpool is goodbye from me, and I'll see you in Rio, and if not in Rio, in Hong Kong. Don't get to say that, do I?
Okay, thank you very much, Richard. Thank you very much for those presentations from Brazil and from Hong Kong. And at our council meeting during the week, we also decided on the venue for 2031, which will rotate back again to Europe, and that will actually be in Poland in 2031. So as your new president, it's really a true honor for me to serve as your next president for 2025 to 2027. The mission of the IAOO is to improve cancer care for oral cancer patients through innovation, education, and international collaboration. And you can see from this meeting that we've fulfilled all of those 3 aspects. So from innovation, we saw presentations on genomics, on immunotherapy, on metabolomics, microbiome, artificial intelligence, robotics, novel imaging techniques, novel technology, and margin assessment. With regards to education, I think everyone in this audience, everyone at the meeting leaves here with a lot more knowledge than what they had when they first arrived. And I'm particularly pleased that we had so many young people here presenting all of their data, and that was particularly good to see. And then lastly, international collaboration. We had 966 people from 55 different countries representing all of the disciplines in oral cancer care. And this is really the only meeting in the world where people from all over the world, from all these different disciplines, come together and meet together. So it's really remarkable for this all to happen. So we leave here really enriched with new knowledge, new collaborations, and most importantly, new friends. I look forward to us all meeting again in Rio in 2027. We are in very safe hands with Fernando Diaz and Louis Kowalski, and I look forward to us all meeting again in 2 years' time. So with that, we are going to close the 2025 meeting. So thank you very much for staying to the end.